Okay, good evening, everyone. A warm welcome to faculty, board members of Indian School of Urology, USI, and dear residents who have logged in for today's second leg of the virtual mock exam 2022. And without wasting much time now, I'll hand over to Dr. Sameer Sen and Dr. Gyanendra Sharma to start the proceeding. A little change. Dr. Shainik Shah, who was to discuss the first case, he'll be coming in the later part of the session, and we'll begin with the case 2, today's case 2, with Dr. Sujata Padvardhan. With this, I invite Dr. Gyanendra Sharma and Dr. Sameer Sen to start the proceedings. Over to you, sir.
Good evening, everybody, and all the best to the candidates who would be appearing for the mock exam. And I think it's a great initiative by USI to give an excellent exposure to students so that they have a fair idea about how actually the final match is. So these are good trial matches for them. Without wasting much time, I would now invite Dr. Sujata Patwardhan to present her case, and I would request Navneet to ask the corresponding student to be ready so that the discussion can proceed immediately.
Yeah, thank you very much, Dr. Gyanendra. And I'm happy to be a part of this initiative of USI. And I think we have to thank Dr. Arun Chawla and for taking so much of interest and forming these groups and keeping on calling us and bring
Navneet,
out all.
can you, yeah, ma'am, I'll ask Navneet to just give you the student's name. Navneet, can you announce the student's name?
Sir, we have Dr. Adhar, Dr. Rohit, Dr. Shruti, and Dr. Suraj for group 6.
Okay. Ma'am, you have 4 students with you.
Okay, okay.
Okay.
Yeah,
so
sure.
you can keep rotating questions and then, okay.
Yeah, so good evening, everybody. And we'll start with the first slide.
Hello, madam. Hello.
Yes, sir. Yeah.
Sameer here. Madam, just a minute. Just a student can introduce themselves so that it will be easier. Just a brief introduction.
Oh, yeah, sure. Yeah.
Navneet, please.
Good evening, everyone. I am Dr. Adhar from.
So I can read
Ma'am,
your.
please
Dr.
go ahead.
Rohit.
Please go ahead, ma'am.
Yeah, please, would you like to introduce yourself in one line?
Good evening, ma'am. I'm Dr. Shruti Pandit from KMC Manipal.
Yeah, hi, Shruti.
Good evening, ma'am. I am Dr. Adhar from CS Medical College.
Yeah, hi, Adhar.
Good evening, ma'am. This is Dr. Suraj from KMC Manipal, ma'am.
Okay. Hi, Suraj.
Hi, ma'am. This is Dr. Rohit from INU Bangalore.
Okay. So all the institutes I know. Anyway, so we'll start with the first slide, please. Can you see the slides?
Not yet,
No, ma'am.
Yeah. Even I can't see.
Sir, I think screen sharing is disabled, sir, by the host.
Screen sharing is only enabled for the co-hosts.
Anshuman, it's not for you. It's for Madam Anshuman.
Yeah. So can we have the slides? So we'll start.
Yeah, please. I'll do that, ma'am.
Yeah.
1 minute. Just 1 minute. Give me. Can you see?
Yeah.
Can you see, ma'am? Yeah.
Yes, sir. So we have this 38-year-old relatively young male residing in Mumbai and who is presenting with flank pain for the period or the duration of symptoms is 1.5 years. And the fever is also for the same amount of time, which is off and on. And the other symptom is dysuria, hematuria, and pyuria. So yeah, anybody from this group, maybe Shruti, you can start. How would you like to elaborate on this history?
Ma'am, first I'd like, my first differential in this case would be renal stones. I would like to know if he has history of hematuria.
Shruti, we don't want renal stones. We don't want a diagnosis. How would you like to elaborate on these points? Now, unfortunately, this patient has quite a few symptoms. He has bilateral flank pain, fever, dysuria, hematuria, and pyuria. So you have to elaborate on all the symptoms. And once the symptoms help us to make it clearer, then you can come to your differential.
So ma'am, with the first symptom, bilateral flank pain, I want to know if it is intermittent, if it is colicky in nature, severe, whether the patient has taken any medications or not for it, and if it is recurrent. Coming to fever, you need to know if it is low grade or high grade fever associated with chills or not, and any particular time of the day where fever is there. From the, he's already having history of hematuria, which I'd like to know more if it is a gross hematuria, if it is associated with passage of any clots. Apart from the dysuria, whether he has any other lower urinary tract symptoms, especially storage symptoms. Also, I would like to know if he's having any other constitutional symptoms like generalized weakness, fatigue, malaise.
Yeah, so you're right that we need to characterize each and every of the symptoms. So this is the very common mistake students do, is they immediately start thinking in their mind that what could be the diagnosis. So don't go that way, go as for the face value of the symptoms. So the patient has bilateral flank pain, which is mild and off and all. And whenever it happens, at times when it is associated with the fever, it is severe and it is in the loin, it doesn't radiate anywhere. Dysuria is persistent and quite troubling symptom. He doesn't have any storage symptoms apart from dysuria, and the hematuria is very mild, and the pyuria and hematuria are occasionally seen. They are not seen on a daily basis or a weekly basis. So from these symptoms, what do you think could be the problem the patient is facing?
Since it is a very chronic history with low-grade fever and dysuria, first differential is urinary tuberculosis. Patient could also have renal stone disease or chronic pyelonephritis is another possibility.
Yeah. So because this patient is a younger patient, does anything else come to your mind?
Unlikely, ma'am, but
bilateral obstruction also. Yeah, stone disease is already mentioned. Something more I'm trying to find out from y'all. Yes, Rohit and Adhar is there, Rohit, Shruti, and who is the other person? Fourth person?
Ma'am, I'd like to also keep in mind vesico-uretary reflux also, no? Because he has recurrent infections and also bilateral flank pain, and he has also void symptoms.
Yeah, so I agree with you. It is very important when there is bilateral flank pain to attribute either the etiology could be related to both the kidney units, or it could be related to the bladder, which is in turn causing bilateral disease. So you have to think not only in terms of vesico-ureteric reflux, because vesico-ureteric reflux is a symptom complex, but it could be something like a neurogenic bladder. Maybe this child has undergone some spinal surgery, or he had a meningomyelocele at birth, or he had a case of postureuretral valve. You don't know. So don't rush to a diagnosis of genitourinary tuberculosis. If the same patient was 50 years old, maybe all this diagnosis would have come may not have come in picture. But here you have to think of some bladder pathology, that in addition to bilateral renal pathology, which could be there as a thing, or it could be bilateral ureteric pathology, it could be related to the outlet obstruction, causing bilateral disease. So the fever which was there and the episodes of severe flank pain could be classified as acute pyelonephritis in this patient. So this is the additional history which I'm giving to you. So with this history, what do you think can be the, could be one more differential?
XGP, ma'am.
Pardon?
Xanthogranulomatosis pyelonephritis.
Xanthogranulomatous. Okay, like I was trying to bring you to a point that maybe he is immunocompromised, or he's a juvenile diabetic, or that is why he has repeated upper tract infections. So from this we can infer that the patient could, because he has fever and pain, and that too pain is in the flank, so he has obviously upper tract infections, and this could be related to various causes. So those histories you should ask. Okay, can we go to the next slide, sir, please? Chawla, sir. Dr. Chawla, can we go to the next slide, please? Yeah. No, I don't think it is changed.
Yes.
I wonder what to do. Because I was here and my Wi-Fi is not supporting. Hello? Sir, can we go to the next slide, please?
Shruti,
Yes, sir.
can you request
Please
Dr.
change the
Chawla to
slide,
move
please.
the, if you can, just help
yes,
us out.
sir.
Yeah. Yeah, please. Because you are in station.
Yes, sir.
Yeah. Please.
So from whatever the history, presenting history we have completed, we won't spend much time on it. In the past history, this patient had repeated admissions to the ESR, that is the emergency unit, with history of flank pain and fever, and then he was, 1 minute, I think, yeah, it has come on. And he had one history of AKI, that is acute kidney injury, where his creatinine had risen up to 3.6, and then it came down and the nadir was 1.4, still on the higher side. Then he was diagnosed as a case of disseminated of Cox with pot spine, and category 1 AKT was given since November 2020. The patient had undergone bilateral PCN insertion, and he is on regular PCN change, but in spite of that, at times he has had recurrent episodes of hematuria and pyuria, and he has an output of 500 to 600 ml from both the PCN. So somebody can answer, what do you think now is the clinical picture?
Sir, ma'am, this patient is having disseminated Cox disease, which is also involved the renal system as a secondary tuberculosis, with bilateral renal involvement and probably the ureteric involvement also, ma'am. So,
why not bladder involvement?
Yes, ma'am. It's a descending infection involving the entire urinary system, starting from the kidneys up till the bladder.
But he has no symptoms of the bladder. He has no frequency
Having
or
dysuria, ma'am.
only dysuria is there, yeah.
Yes, ma'am.
Yeah.
And now he is on ECN as well. So his bladder symptoms might not be very reliable.
So in general, if you go to the symptomatology of tuberculosis, it doesn't present with flank pain. The symptoms are mainly in 40 to 50% related to the bladder in the form of storage symptoms, dysuria and hematuria, than pyuria. Okay, renal pain doesn't feature higher up. Then there may be symptoms related to the scrotum or to the testes, but presentation of a patient with AKI, that is renal injury, so much of renal destruction resulting in renal failure at presentation is not a very common feature. So if this is happening, then what else do you need to ask?
We need to rule out any immunocompromised status.
Yeah.
Tuberculosis.
Yes, ma'am.
Apart
And along
from
with it,
tuberculosis, whether he has any other immunocompromise which can compromise him immunologically, like
HIV.
HIV,
yeah.
ma'am. Then
Yeah, what else?
Juvenile diabetes. Juvenile
Yeah.
diabetes or other patient maybe HBS positive or any history
Yeah.
of patient
Yeah.
maybe
So all
transplant
this
in the
history
past. On
needs to be asked. Okay. Yeah. So what other past history would you like to know? So we are all biased to tuberculosis now, because obviously if he has been diagnosed as pot spine and received AKT, we will be very much biased towards tuberculosis. But what other history would you like to ask? And then we'll go ahead.
past history of medical intervention.
Yeah, so medical and surgical
If patient has
interventions is important because yeah. So though they have given only history of bilateral PCN, it is your duty to ask whether he took his AKT regularly, whether in spite of now you're seeing that in spite of AKT, that we are saying that the patient is on bilateral PCN. So obviously the treatment has not been complete, or it has been attempted and it is failed. So all these things could be possibilities. So asking the surgical and medical history of this patient is very important. Yeah. Can we go to the next slide, sir? Yeah. So this is just a slide which right now doesn't give you any information. So his appetite is normal and he doesn't have any constitutional symptoms of weight loss and anything. He no family history. In this perinatal hypoxic ischemic injury and epilepsy has to be kept into mind when we come to the management. So though it may not be related to this disease as such or the disease process in this patient, we have to keep this history of epilepsy when we come to management. Yeah. So next slide, please. So what will you ask now? Yeah. So, okay, general examination has been told to you. It seems to be normal. Though they have written that skull and spine is normal, you have to look, you have to ask more things like, does he have any fixed flexion deformity? Is his gait normal? So like try and save that this patient had pot spine. So in your mind, you're thinking that they may say it is normal, but you ask, so that gives an examiner a feeling that you are also thinking. So yes, I think you can read this slide. I won't read it for you. But in general, everything is normal apart from bilateral PCN. What other things do you think you would examine? Suppose I don't show you this slide. What are the other things you need to see in examination?
Ma'am, we'll do the
Examination
abdominal
of
and genital
lymphadenopathy.
examination. In
Yeah.
the
Genital
abdominal,
exam.
I will look for any palpable lymphadenopathy, renal angle fullness, or any lump palpable.
Where will you find lymphadenopathy, Aadhar?
Ma'am, supraclavicular I will look for, or if my
It's basically generalized lymphadenopathy, mainly supraclavicular and axillary, because considering this previous tuberculosis.
disseminated.
Disseminated.
Yeah, so here I would like to point you that when tuberculosis involves the lymph nodes, okay, normally it involves the pulmonary system, and from there it gets disseminated and secondary reactivation of tuberculosis occurs. But if tuberculosis primarily presents as cervical or axillary lymph nodes, here usually this portrays a picture that the immunity of that person is good enough, and it doesn't usually cause generalized lymphadenopathy. It's usually limited to the axillary and cervical this thing. So person who is presenting as disseminated infections, having spinal tuberculosis, very unlikely that. But what am I trying to ask you here is you need to know what are the features of tuberculosis in the testes, scrotum, and on PR. Okay.
And testicular, yes, ma'am.
Epidermis will be
cranky bead appearance, beaded vas deferens, or posterior scrotal sinus, ma'am, we get in case of tuberculosis in late cases. And on DRE, we get the hard prostate, ma'am, fibrosed.
Okay.
External genitalia also to be
so,
examined. Orificial tuberculosis.
Papillonecrotic, orificial, and yes, these two will look on the urethra.
Yeah, I've not seen any urethral tuberculosis till date, but yeah, that's what is told in the textbooks. Okay, so now we have finished both history and this thing. So how would you what would be your clinical diagnosis? Yeah, anybody of
Genitourinary tuberculosis secondary to previous disseminated tuberculosis infection. I would like to consider that as my first.
Yeah, genitourinary tuberculosis is pretty vague diagnosis, right? We have got much more information after his history and examination. So would you like to boil it down?
Renal tuberculosis. Tuberculosis involving the kidney. Also involvement of bladder, because he has issue of and ureter and bladder. That is kidney, ureter, and bladder, because there are strictures suggested because the PCN was poor, and he has issue of dysuria, so bladder component also might be there. And already there are kidneys already involved. So the tuberculosis that is involving kidney, ureter, and bladder.
Okay, with
renal failure.
Obstructive uropathy with renal failure.
Yeah. So don't forget that. I should not require prompting because obstruction is evident and renal compromise of renal function is also evident, right? Both things were told to you. Okay. So what investigation would you like as the first investigation?
Ultrasound as an extension of physical examination would be the first investigation.
Okay. You don't want to know any hematological, any urinary examination?
Yes, ma'am. That also will come, but as
ultrasound. So in general,
Mm-hmm.
Shruti, like in an exam, like though ultrasound is a rational investigation, which anybody would say, I may not agree to it. But in an exam, the system is you start with urinary test, then proceed to hematological test. Then you can say that you would ask for any specialized test related to this on a later basis. And an ultrasound, why I would not agree in this patient is You tell me, why would an ultrasound be a superfluous investigation in this patient?
They would, we would not be evaluating the upper tract superior to difficult with the PCN in situ. We will be able
And
to
the
tell
bladder
whether
would
the
not be
PCN is in situ or not. Also, the bladder will not be distended. So.
And the
Yeah.
pathology of operator cannot be delineated by ultrasound.
The best answer in this case would be that we already know that this patient has,
It's a known
we
case.
know the organ which is causing the problem. We feel that all the three things like the ureters and the kidney and the bladder is also involved, and an ultrasound will be superfluous because we need to have concrete information in this patient. An ultrasound will be useful when we are little in a clinical dilemma as to know the organ of origin or the disease itself, or we have thought that this could be reflux or stone disease or something like that. So in that, otherwise, I think an ultrasound is not needed. As a MCH exam, you would definitely require a proper radiological investigation. Okay. So next slide, please. We are showing you the urine routine microscopy. Next slide. Okay, yeah, urine routine and hematological investigation. So what is the definition of pyuria?
Ma'am, it is more than 2 WBC per high power field or more than 10 WBC per millimeter cube of the urine.
Okay. So this patient has pyuria and hematuria. What else is missing in this slide?
pH is missing,
it is
and the
pH is
specific gravity we need to know, ma'am.
Okay. So why is it called sterile pyuria tuberculosis?
The culture will not yield any
Bacteria will not get
in how many
percent? Will not be seen on regular microscopy, ma'am. We have to do a ZN staining or an Oramin rhodamin staining to identify the bacteria, but only the pus cells will be seen in the background of it.
Suppose I tell you that a few bacteria are seen, then which are the bacteria which are routinely seen and in what percentage they are seen?
A false positive result may be there because of the lactobacillus or the corynebacterium.
That is for AFB Aadhaar, not for not on urine routine micro. We are on routine analysis.
On routine analysis, the commonly seen bacteria would be the skin commensals if the urine is collected from the perurethra, like Staphylococcus epidermidis. But in this patient, we might be collecting it from the PCN. So the skin commensals like Staphylococcus could be the organisms which can be seen.
Suppose I tell you that the culture is positive, urine culture is positive for a common organism. Which organism is it? So E. coli is usually associated with tuberculosis infections, and it can be seen in almost 10 to 30% of patients with tuberculosis. So not necessarily that it will be sterile pyuria all the time. But in addition, I suppose you all know the causes for sterile pyuria.
Yes, ma'am.
Yeah.
Ma'am, one is genitourinary tuberculosis. It can be Stratton calculus, or it can be interstitial nephritis, or maybe chlamydial infection, ma'am.
Mycoplasma.
More common.
Partially treated urinary tract infection can also show sterile pyuria.
Yeah. Yes. What else?
A bladder mass may show sterile pyuria.
So patient who is post-operatively and treated with antibiotics also will have sterile pyuria. A person on antibiotics will have. So these are common causes, plus all other infections which are not responsive to antibiotics, like fungal infections, parasitic infections, genitourinary tuberculosis, malignancies, stone disease, which is there for a long time. Okay. Yeah. So then can we go to the next slide?
Yeah, because we are shortage of time. So
okay, yes, sir.
Yeah,
we'll go directly to the
little area.
Yeah. So just sir, can you show the hematological investigation? I think that was missed. Yeah, so you can see that the creatinine is 3.6. The rest of the things are okay. Sodium is low and HB is also low. Okay. So can we go to the next slide? So we'll skip the ultrasound. So I feel an ultrasound is superfluous in this patient. So here creatinine being high, again, you have to ask for an NCCT. Can we run through the slides, sir? So can we go back, sir, for one or two slides? Yeah. So the renal picture. Yeah. Yeah, I think here this is fine. So as we are short of time, I would definitely like to point to you that when you are looking at a CT scan of tuberculosis, the features which are commonly seen is the calyces are not proportionately dilated. They are disproportionately involved because of infundibular involvement, and the pelvis is usually shrunken. Pelvis is not dilated in comparison to the calyceal dilatation. So there is a difference between the calyceal dilatation and the pelvis dilatation. Then you have to look for thickening of the ureter. In this patient, especially because he had Pott's spine, you need to comment on the spine. So how much time do we have?
Ma'am, we can have 10 minutes more because
10 minutes
we
more.
10 minutes during our the first introduction and
Yeah,
all.
so just for the lack of time, I'm trying to point out to you the features of genitourinary tuberculosis. There may be presence of cortical abscess, perinephric abscess. There would be disparity in the size of the kidney. And ureteric dilatation is not much, but the thickening of the ureter you have to see. Okay, then coming to the, there would be calcification. Now the calcification in tuberculosis is also of 4 types. You should know them. There is a very good article by Dr. Suleiman Merchant on IVP, CT scan and MRI. Also ultrasound. I think please go through his these things. It is necessary for you to know these features of tuberculosis, the radiological part. So one of you just please, if you could see all the CT, I'm not sure whether you have seen them for an adequate time. So can you all comment?
Both the
Pilot
kidneys
is,
both the kidneys appears enlarged with disproportionate enlargement with parenchyma, and ureter appears dilated, and there is make out some perinephric fat stranding, and the ureter wall I couldn't make out properly, and bladder appears distended with the bladder wall appeared bit thickened, and the spine couldn't make out any lesions in the spine as such. And there was some calcification was noted in the pelvis region.
Yeah, so I give it to you because you are not seeing these pictures in reality, and they were pretty fast. I think you have covered all the points. The bladder, which seems to come out of the true pelvis, means capacity can be normal. So this is one more thing which you can radiologically see. Otherwise, usually if it is a small contracted thimble bladder of tuberculosis, it is confined to the true pelvis on CT scan. Okay, comment on the prostate if at all you find any features. Yeah, and yeah, calcification. So I leave it to you all to read these articles. It's necessary before your exam. So from this radiology, are you happy with whatever imaging was given to you, or the information is incomplete?
It's incomplete because we don't know the electric involvement. So I would like to
bilateral nephrostogram we can
bilateral nephrostogram because already PCN are there. I would like to do bilateral nephrostogram.
Yeah, I think by mistake they showed you the nephrostogram. So in addition to nephrostogram, any other investigation you want?
MRI with T2 weighted images can be
Histogram
helpful.
also I would like to know, ma'am. Because if there is complete stricture, I will not be able to know the bladder total capacity. So cystogram also with the nephrostogram I would like to do same time.
Yeah, so yeah, I agree with both the investigations. They are necessary because we don't know the anatomy of this PC system. We don't know the anatomy of this bladder from this CT scan. Yeah, so can we proceed to the next slide? So this is on the right side. And the next slide.
You want this one or next?
Yeah, no, this previous one, sir. Yeah.
Okay.
So now somebody describe in this in short.
It is a bilateral, I mean, it's a nephrostogram of bilateral kidneys. On the left side, there is a cutoff of the contrast at around the proximal ureter at the level of around L4, and the pelvis is not distending with the maximal dilatation of the calyces, especially the proximal calyx. The pelvis is not well delineated. Whereas on the right side, the pelvis is seen with multiple kinks in the ureter with asymmetric ureteric margins.
Yeah. So just for lack of time, I would like to say that in this description, you need to say that there is quite amount of the cortex which is destructed. The calyces are dilated. And on the left side, you can see infundibular stenosis. And this sort of pelvis, which is very intrarenal and it is pulled up, is Kerr's pelvis. And you can see a stricture at the PU junction. You need to mention that the entire ureter is diseased on both the sides, because this is not a normal caliber of the ureter. It is dilated at some parts, narrow at some parts. You can see various kinks. So all these things should be mentioned in addition to the level of obstruction. And the whole system is diseased. It is not as if this is a normal calyceal outline. You can see it is fuzzy and it is irregular, right? So these points you need to mention, otherwise you are doing okay. So you wanted a cystogram also, right? So can we proceed to the cystogram, sir? So in a cystogram in a patient with tuberculosis, what else do you think? What else do you mainly look for apart from capacity?
We look for reflux, ma'am.
Reflux.
Yeah.
Reflux.
Yeah. So it is necessary to look for
whether it is that's what active or passive.
Okay.
And the
But
urethral involvement.
Yeah. So prostatic involvement. Have you seen cases of prostatic involvement of tuberculosis? The posterior urethra is dilated and there is reflux of contrast in the prostate, and it looks as if the it's like a flower, like the prostatic fossa is dilated usually, and you can see a extravasation or intravasation of contrast inside the prostate. This is a common feature seen. There may be fistulae which may be present and calcification. In the bladder, obviously, you have to look for the size of the bladder, whether there is any contractures like thimble bladder or clove-shaped bladder, and reflux. And reflux would occur only when there is
laterally placed
or laterally placed patulous orifice, golf orifice.
Might be because of the reduced capacity itself, and also because
in
of
this patient, are we looking for reflux?
No, ma'am.
No.
Why? Because he has bilateral ureteric strictures, which we have diagnosed higher up, right? So in this, the whole reflux will occur when the UV junction is the only part of the entire system which is involved. And the rest of the ureter is not very badly involved, or it doesn't have much of strictures. When there are so many strictures high up and a total cutoff, there is no chance that reflux would be seen, but you need to keep it in mind. Yeah. So now what more? Do you want any more investigations? Have you proved tuberculosis?
No, ma'am.
No,
We
ma'am.
need
No, ma'am.
urine
Urinary
smear or
PCR.
culture for AFB, a gene expert.
And also we have to get a culture
Shruti, I would
sensitivity.
think this
because
answer
might
is
be
coming
different.
from. No, I don't agree with you. See, why do you want to urine AFB now? What is the sensitivity of urine AFB? Basically, why do you want to prove tuberculosis here? Isn't the radiology a major criteria to say that this is tuberculosis? I hope you know the major and minor criteria.
Yes,
Okay, the major criteria is, yeah,
Major
tell me.
criteria is AFB smear or culture positive, gene expert or PCR positive, or a pathology showing a granuloma. Minor criteria is if the patient is having any radiological features suggestive of tuberculosis, it could be CT, MRI, or IVU, or if he has a raised ESR or hematuria, or he has
Pulmonary changes on X-ray.
pulmonary COX. So one major criteria on two minor are required for diagnosis.
Yeah. So here we should have asked for a chest X-ray. That is one thing which you all forgot. And the other thing is, why do we want to know whether this patient is still having tuberculosis? Is because we want to know whether
5% resistance.
Yeah,
Active
we need
tuberculosis.
to know the
Culture
MDR
sensitive.
tuberculosis or whether this is
With-
so otherwise
with
our
5%
management will be dependent on it. No? So it is important to know that in spite of AKT, in spite of everything, does this patient still have tuberculosis which is active in his body? And for that, Shruti, your answer of urine AFB, I don't agree, because we already have PCNs. And a urine which is aspirated or which is collected from the system or the from the upper tracts has more sensitivity for diagnosis on microbiology. Okay, when suppose you didn't have PCNs and you the patient was voiding normally, then maybe urine AFB is a right answer. So when you have this urine which is being collected directly from both the PCNs, you can send it for urine AFB there, and you can send it for CPNAT, or if you call it PCR, that is
TB
fine.
PCR.
Yeah, so TB PCR. So here we need to look not on, and also for culture, because here culture is important because he's a case who has been previously treated with AKT. So now we need, in a patient who has been treated with AKT and again develops a tuberculosis within a period of how many months?
1
6
year.
months.
Huh?
Madam,
6
we
months.
need to wind up, madam, little.
Okay.
We are a little ahead
So
of.
we need to know whether the rifampicin resistance and this. And now we come to the last part. I'm sorry that this part could not get much of attention. What is the what is the surgical management which you can so this patient needs to receive CAT1 treatment again if provided the is not showing any resistance. The CPNAT report or the culture report is not showing any resistance. Otherwise, we need to go to the second line of drugs. And what could be the surgical management? So we have systems which are both poorly functioning. We have bilateral extensive ureteric involvement. Bladder involvement is not very obvious, but considering these two things and a creatinine of 3.6, tell me the options and we'll just stop. Leave the patient alone. I can see that from your face. Any other option? So if you remember the system on the left side, which has infundibular stenosis, such a narrow pelvis and hardly maybe 4 or 5 centimeters So you need to know the differential renal function. We were told that the PCN output is 600 ml. At present, the patient is not requiring dialysis, but the case needs to be evaluated after about 6 weeks of AKT, whether any further fibrosis is happening. And in such a patient, the answer is very difficult. Reconstruction of such a ureter will obviously, the bladder, we are not sure. We need to do a cystoscopy to see whether there is involvement, as he had hematuria and pyuria. Whether we could utilize this bladder for bilateral strictures is a very unlikely thing. Secondly, we could go in for use of bowel, but the creatinine is on the higher side. So there is an option of a rat tail anastomosis in this patient, where only about 15 to 20 centimeters of ileum is anastomosed to the dome of the bladder, and both the ureters can be put in this rat tail anastomosis. This is one option. Or a short ileal conduit, which is kept on continuous drainage to prevent any absorption of urinary solutes, is a other option. Or the third option is to leave him alone and take it as it comes, because with creatinine 3.6 and at the age of 38, we know that he can't go ahead a long way on with both these things. And then obviously the options would be nephrectomy followed by transplant. I'm sorry we could not spend more time on discussion. Carry home messages is definitely, I feel, don't be in a rush to give a diagnosis on your first slide. Elaborate the symptoms. Think that whether this is bilateral renal disease or it is related secondary to the bladder. That is important. Whenever a patient of tuberculosis comes, you always need to know whether at present he is having active tuberculosis, and whether he has additional immunocompromised features which are contributing to it. In addition to it, always ask for an investigation which will tell you all the information. I would differ from asking an ultrasound in this patient, because it doesn't give you all the information. And here you have to manage the patient. You need to know all the information present. Always rule out pulmonary tuberculosis in this setting. Ask for the culture, and whenever you are asking for microbiological test, if it is possible to directly take an aspiration of the PC system, or from the ureter, or from the testes, or from the epididymis, that is more useful than doing a routine urine test, though urine AFB remains the gold standard for diagnosis. And please utilize the existing government systems which provide free diagnosis for such patients who are already at a low socioeconomic status. And it is, whenever you go, I'm sure all of you will pass, and you will go and become consultants. So always remember that you need to register these patients with our RNTCP centers, because in this way only we can progress and eradicate tuberculosis. And thank you. And obviously, you know my number and you know my email address. If there's something more, you can correspond with me. Good night. And
Thank you.
Thank you, Dr. Chawla, and thank you, USI, for this opportunity. Thank you, sir.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. Two aspects which I would like to emphasize, and I would like to have ma'am's opinion also for the same. Should we ask history of being COVID positive, especially because he has been an immunocompromised patient? And secondly, when we use the terms like pus cells in urine, is it better to use the terminology WBCs in urine?
Yeah, definitely, sir. COVID is a part and feature of our life now. So we need to, because the management would differ if he's positive, and that part we forgot, I suppose. So we need to include it. And yeah, you should use WBCs in as a terminology.
Thank you, ma'am.
Yeah, thank you, sir.
Chawla sir, can we start now with the second case?
Yes, please, sir. Go ahead. Please. Yeah, go ahead.
Is it Dr. Shrenik Shah who is presenting or Dr. Lakshman?
No, Dr. Lakshman Prabhu is there.
Yeah. So the stage is all his, sir. Lakshman sir.
Yeah.
Yes.
Before that, kindly start the student's name again. The same student will be there, or will change?
We have Dr. Amit, Dr. Manish, Dr. Prateek, and Dr. Shanti.
Okay. Yeah. Now, good evening, everybody. It is 6:50.
Sir, if you can slides, you can just hide and bring it to the first. Yeah.
Yeah, it has come to the. Are you not seeing the first one?
No, sir. Follow up.
Okay. No, mine.
Where have you?
I'll stop sharing. Yeah. I'll come again. Yeah. Okay. Yeah. Is it okay now?
Yes, sir.
Sir, kindly make it full screen.
Yeah. Is it first slide?
Yes, sir.
Are you seeing? Yeah. Fine. Am I okay, Dr. Chawla?
Absolutely fine, sir. Okay, full screen.
I think. Yeah.
Make it slideshow.
Yeah. No, it's a slideshow only now.
No, sir. Here it is not.
Oh, really?
No,
I can
check
on my.
So this can be projected from our end. Probably some issue.
No, okay. No. Yeah. No, I'll come again. It should be easy for me.
No issue, sir. No issue. No, Ram, sir.
This one.
Dr. Samir, this is Dr. Ranjan.
Yes, sir. Hello. Good evening, sir.
Hello. Yeah, good evening. I have sent my presentation
is
in the WhatsApp
okay
group.
now?
Is it possible to present it from your end? Then it will be convenient. This loss of time will not be there.
If it's
okay,
okay,
let me check it.
Shall I get started?
Absolutely, sir.
Yes, sir. Please start.
Thank you very much. Good evening, and all my friends, young friends, who are going to be, I think, Group 7. What I'll do is, I think we are running a little late. So let me, if you find me rumbling through this, please pardon me. I will treat you like consultants. And how does it move next? Yeah. Yes. Yeah, next one. Okay, this is, sorry for the hiccup. This is the history in brief given by the mother, and that mother is the informant. This was a 2-year-old female child, full-time normal delivery, born on 18/5/2020, no consanguinity. Mother says she never underwent an anomaly scan. On postnatal day 5, the child ran fever, and the child was treated as presumed sepsis in the NICU of a medical college hospital. And the child was all right after 24 hours. This is the information which I got. And 1 year later, when the child was all right after that. 1 year later, again, a febrile episode without convulsions, treated by a general practitioner. Urine analysis showed WBC urea, treated with, she said some syrup was given, the child was all right. And a year later, that is in the month of April, the child was febrile again. And this time they did a total count, which was 11,700. And from the notes, WBC urea was present. Now, all my friends, this was the case scenario which came to my office. And if you would like to know anything more before we get down to examination, you can ask me, I will provide it. And you have to justify or substantiate why you want that particular information. Shall we get started? Navneet, can you tell the names of the...
Navneet, names, please tell Dr. Lakshman.
Names I'll take down because I'm not able to see them. Can I have the names? Yeah,
Sir, Dr. Amit,
Amir,
Dr. Shanti, Dr. Prateek, and Dr. Manish.
Prateek, Manish, and Amir.
Dr.
And
Dr. Prateek, Dr. Shanti, Dr. Amit.
Yeah. Okay, we'll get going with the A for Amit. Amit, what are your thoughts on this? Now, if you don't answer, I will ask you a question. Just let us have some thought on postnatal day 5. The child ran fever and treated as presumed sepsis. What are the thoughts at this stage?
Sir, post-op day 5 with fever, we have
postnatal.
Yeah, postnatal day 5. First, a child with fever. First thing we'll have to think of is a urinary tract infection.
Okay. Yeah. Shanti, you agree with them? Dr. Shanti? Okay.
Yeah.
Agree or not? He says urinary
yes, sir,
infection.
it can. Yes, sir,
Yeah,
it can be because of
The
urinary
correct
tract
answer is
infection.
It can be, but
yes.
you know, let me tell you that when the child is febrile in the perinatal period, you must remember one thing in pediatrics. In pediatrics, infection is taken to a child, quite unlike in adult population. An adult goes to the infection. Okay, apply this logic. Usually it is umbilical sepsis, or you know, during their suction they might have introduced, it could be a meningitis or it could be respiratory infection. Urinary tract infection also is one of the causes, but these are the common causes. Okay. At the age of 1 year, you can definitely consider a urinary tract infection. Okay. Now, Prateek and Manish, what you would have done, sir, because this was treated by a general practitioner and probably the child was very stable. He thought it was a urinary tract infection and the child was given antibiotic syrups. What you would have done if you had seen the child? What would have been your approach?
Sir, they have done a urine analysis. Along with that, yes, we would have advised for a urine culture, sir.
Very good. Yes. Yes.
And
yeah,
along with that, if we are suspecting any urinary tract infection, we would go for ultrasound KOB, sir, scan.
Wonderful. Wonderful. I agree with you. Only thing is, you should know the nuances and the vagaries of collecting urine in a female child at that age. I am not going into that, but I'm sure you know about it. I'm just making an observation. You are right. A culture should have been done and imaging should have been done. We'll come to that. I agree with you. Now, it was not done. The second year, again, the child ran fever and total count was high. There was pyuria. This time, you will have the same approach or you have a slightly different approach? Prateek, once again.
Yes, sir.
You will have the same approach. There shouldn't be any, because
yes,
you know, that is the thing which should have been done, not been done. And you would want a culture and an ultrasound. Okay? Culture and an ultrasound. Now, before that, okay, this is the ultrasound. The culture showed E. coli, 10 raised to the power 3 colony forming units per ml of urine culture. And this is the ultrasound. This is from the outpatient notes which had been done before the child was referred. This is what it read exactly. I can't give you more details, but you can ask me what is a complete ultrasound in a child with the fever suspected to be from the urinary tract.
So in this ultrasound, they have mentioned only about the left kidney and they have not mentioned about the other kidney on the right side.
Right kidney is normal. Right kidney is normal.
Sir. And there is no mention about any bladder anatomy.
Exactly.
Have not been mentioned.
Exactly. You are right. All the guidelines say that the upper tract and the lower tract should be studied in the initial ultrasound. We have a child with the normal looking lower urinary tract, normal right kidney, normal looking right kidney, and the left kidney has shown a AP diameter of 14 millimeters, all calyces dilated with a little cortical thinning here and there. Normal, abnormal, and what do you call this? This is obviously abnormal.
Normal, sir.
Yeah. This is not normal. This is abnormal. What is the cutoff of AP diameter? Less than that, you will not worry.
7 mm.
Okay, Shanti says 7 mm. Okay. So now, this is the current scenario because I will just want you to go through it. The child is active, now afebrile. These are the parameters: weight 12.9 kg, height 88 centimeters, abdomen soft, no mass, no tenderness, spine normal, introitus on inspection normal, female child. You want to add anything to this? I'll ask you a question. Shanti, why would you inspect the introitus?
To look for any ectopic ureter or any dysfunctional voiding, to look for the collection of, there's no history of urinary incontinence.
Very nice. Actually, you should have brought it out in the history, because this child had only fever. And when you probe the history, we could have elicited this. And if you had elicited that, it would have made a lot of sense. But nonetheless, as a complete examination, to complete the examination, you should inspect the introitus. What about spine, Manish?
Sir, spinal deformity, sir, meningocele, myelocele.
Yeah, those would have been if there was an obvious deformity, the mother would have told us, or we would have known it. So what are you specifically looking for, if at all you are worried about a spinal dysraphism?
So sacral agenesis.
No, maybe a dimple or tuft of hair and such stigmata, you will always look for. That is the correct answer. What would you do now at this stage? Because we have to wind up in about 15 to 20 minutes time, to be fair to the other speakers. So let us rush through this. Yeah, what would you do at this stage? A fever, you have done an ultrasound. There is left upper tract dilatation. There is no mention about the ureter. What should be the next step?
Sir, considering the left-sided dilatation of the kidney, sir, we can go for top-down approach, sir.
You want to do a top-down, top-down approach. Yes, how many of you are for bottoms-up? Top-up.
I would like to go for a bottom-up approach, sir.
Yeah, bottom-up. Okay. So Shanti said that she will start with the lower urinary tract. Before that, this time, before you do a VCU or a MCU, bottom up, you should have had a culture done, which is normal, no growth. Biochemistry is normal. Urine analysis is now normal. Probably the ideal time to do. Is it ideal time to do a bottom up now?
Yes, sir. It's an ideal time to do because the urine is sterile.
Safe. Yeah. Okay. This is the MCU. Shanti, all yours. Read.
The plain film shows bloated bowel. Probably the child is also constipated.
Okay, very good. What is the relevance?
Cannot grossly make up.
What is the relevance?
There can be a bowel bladder dysfunction.
Very good. You have to. That is the only sign, in BBDs. Very well done. Yes. Next, bladder.
And yes, sir. The bladder, the contour of the capacity of the bladder appears to be normal. Contour of the bladder. Contour of the
bladder also looks normal. Yeah.
Bladder, and there is no reflux.
There is no reflux. Yeah.
Filling phase and also in the voiding phase, I cannot make out any reflux.
Yeah, urethra, whatever is visualized looks normal.
Visualized appears normal. Yes, sir. Bladder neck also appears normal.
Now what shall we do?
Now we can go
bottom up. Now bottom is over. Now you have to go up.
Yes.
What
sir.
do you do, Shanti?
Since the child is 2-year-old, I would get a Renogram scan done.
Hang on. At this stage, what is your diagnosis? All of you, Manish, Amit, Shanti, and Pratik. What is your thought?
It could be a pelviureteric junction obstruction, sir. Congenital.
PUJ obstruction probably is the most plausible or most probable problem here.
Yes, sir.
Right? Okay.
Yes, sir.
So now the up part. So you wanted a diuretic renogram.
Yes.
Here it is. What are the points to make? Shanti, listen to me. What are the points you need to make a diagnosis of a PUJ?
We can grossly look at the perfusion. Yes, a curve. Yeah. If it is a type 2 obstructed O'Reilly curve.
Yeah, 1 minute, one at a time. Perfusion curves look okay to you, both the sides?
Yes, the perfusion curves look.
Yeah.
Yes, so they look okay, sir.
They look okay. Now come to the drainage curves. Washout curves. What are called as the washout curves?
The left kidney, the curve looks an upsloping, sir. Obstructed type 2 Radiological.
For your kind information, the diuretic was administered along with the isotope. So what is that protocol?
F0 protocol.
F0.
F0. Yeah, very well done. F0. So now you look at the curve. Okay, look at the curve, you look at T half, and then also you look at the differential function. Now let me draw your attention. The differential function on the left side is 53.24. What are your comments?
It can be an overestimation
Yes,
because of
exactly.
a hydronephrotic kidney and larger area of uptake of the...
It is an overestimation, you are right. So now are you happy with your diagnosis of a PUJ? Going by the curve.
Peak to,
Yes, no, sir.
going by the curve, yes, sir, it looks obstructed.
It looks like a, okay. Now, this is the report. You are right. Enlarged and hydronephrotic left kidney shows preserved cortical function and obstructive drainage, obstruction likely to be at the level of pelvic ureteric junction. Why have they said likely?
Because of the grossly dilated kidney,
yeah,
which overlaps the region of interest, they can not sometimes exactly make out the point of obstruction.
Exactly. So, can we stop short here and start treating the child, or you want anything more than this? What are the investigations available? Child is all right now. Child is afebrile, no pyuria, no infection, urea create normal. You can do any investigation.
Because it's only a 2-year-old.
Yeah, 2-year-old, yeah.
2-year-old child, we can avoid radiation exposure by CT and we can go ahead with treatment.
Yeah.
During the surgery, we can plan for a retrograde pyelogram to note the site of obstruction and then plan the incision or port placement.
Yeah, you are right. You are right. Many workers go with the ultrasound estimation of parenchymal thickness, the DTPA urogram, and maybe a retrograde ureterography. So if you are asked to choose between excretory urography, CECT urogram, and MR contrast urogram, which one will you choose?
CECT will be very difficult, but if it is an adult patient, then probably CECT will be.
No, this is a child. Shanti, this is a 2-year-old baby.
In a child, I will definitely prefer a retrograde ureterogram during the before the procedures.
Okay, I accept that. Between CT and excretory urography, IVU, which one would be your choice?
IVU, sir.
Here you are. Does it confirm the diagnosis?
Yes, sir, it confirms the diagnosis. There's a grossly hydronephrotic left kidney with all the calyces dilated and dilated pelvis, and which shows an obstruction at probably level of L3.
Yeah.
Rest of the ureter is not opacified. There is contrast in the bladder, probably from the opposite kidney.
Yeah, wonderful. What intervention? Conservative or surgical?
Surgical intervention, sir, because the child is having episodes of recurrent urinary tract infections, and there's a definite obstruction of the
suspected. Yes.
Yes.
There is significant dilatation.
Obstruction, significant dilatation, cortical thinning, which shows an indirect evidence of compromising renal function.
See, while on the IVU, what is crescent sign? Anybody can answer. Manish, Amit, Shanti, Pratik. What is crescent sign? This is a excretory urography sign. I'll be very happy if you answer this. You heard of this? The crescent sign is actually a sign seen on IVU. You see the crescents on the calyces. That's because of the transverse orientation, or the collecting ducts, which are normally vertically oriented. They're perpendicular to, arranged in the pyramids, are stretched across, and you get crescents. And in the good old days, it was considered as a sign of recoverability. Okay, that's it.
Okay.
Now, you have decided to intervene. What will you do? What intervention will you offer, Amit?
So for her, the option of dismembered pyeloplasty.
1 minute. And Shanti has already put in a scope. She has done a retrograde study and she has shown that the ureter is normal. There is a Peugeot narrowing and a jet effect. It is entering a collecting system like this, exactly like this. Now take on, Amit.
So options of laparoscopic or open dismembered
So you have to do a
pyeloplasty.
pyeloplasty. And what would be your choice of pyeloplasty? How do you classify pyeloplasties, Pratik?
We can classify pyeloplasty on dismembered and non-dismembered pyeloplasty.
Wonderful, wonderful. Can you give an example for dismembered pyeloplasty?
Anderson-Hines pyeloplasty.
Can you tell us one contraindication for Anderson-Hines pyeloplasty?
Intrarenal pelvis, scarred
yes.
intrarenal pelvis.
More often than not, if the Peugeot narrowing is very long, that's why Shanti wanted to do a retrograde study. If it is very, very long, then it might be, a case for a flap procedure that is non-dismembered.
Yes.
Now, I think you've done very well, all of you. A few points. Hydronephrosis in the unborn, postnatal evaluation, first febrile UTI, renography protocols, intervention, transition nephrology, and follow-up. These are the things which will be asked to you. Of course, in addition to that, once in a way, the examiner may spring as to in what percentage it is bilateral, when does it coexist with VUR, and all such things. Each dilatation is always a sign of obstruction. You all know about it. We'll touch upon one of these things. Now, hydronephrosis in the unborn is an old terminology. Now you say UTD, urinary tract dilatation. Okay. Now, you should know the normal values for various weeks of gestation. 16 to 27, less than 4 mm, more than 28 weeks, less than 7 mm. These are normal values. And postnatal is always done after 48 hours. Can anybody tell us why it is done after 48 hours?
Because in the first 48 hours, there'll be dehydration and we cannot get a correct estimate of the...
There will be relative oliguria and therefore you may miss a diagnosis. Now, of course, you have antenatal, postnatal, UTD A1, A2, 3, and this is a way you classify it. And then there are various cutoff values which you are familiar with, or if you are not familiar with, kindly familiarize yourself with them. Like was pointed out by many of you, the first febrile UTI, what will you do? You will start with an ultrasound. If there is UTD, then see whether the child needs hospitalization, IV antibiotics, and then once you treat, if the response is good, then you can do a further evaluation. This is our pathway, okay? Further evaluation and a renal scan for exclusion of VUR. If there is no response, of course, you have to consider a diversion. Now, I think we have touched upon this. You know the various patterns. The conventional approach is to give Lasix at the end of 20 minutes of administration of the radioisotope, that is F plus 20. I would like to draw your attention to this article which appeared in 2015 in Indian Journal of Urology. Please go through this. F plus 0 and F minus 15 are superior to the conventional F plus 20. However, in children, administering diuretics along with isotope is the best because you disturb the child least and there is no problem of diuresis setting in early and the child wanting to pee. So you must be aware of all these and the various curves. The type 1, the type 2 obstructed, which you saw in this child, and then the hypotonic, type 3A, type 3B, and then of course the delayed compensation. Always remember the acronym FRCS when you interpret diuretic renography. FRCS, that is the determinants, which are there: the functionality of the kidney, the rate of secretion of or excretion or the GFR, then C is the capacity of the pelvis, and finally the resistance at the Peugeot, that is stenosis. So if you remember FRCS, you will know, you will interpret the curves much better. Now, the interventions you pointed out that broadly they are, this is of course, forget endopyelotomy for the time being. Hellstrom, what is Hellstrom? This operation is done when you want to transpose the vessel, which is causing an extrinsic obstruction, but you all know that the aberrant vessel is seen in more than 50%, 15 to 52%, but then more often than not, it is a concomitant or an innocent bystander, there is an intrinsic defect. So they would need a pyeloplasty. Now you have broadly Anderson-Hines, which is dismembered, and the flap procedures. Foley's YV, Culp deviated, that is straight flap, Cardino Prince, vertical flap, and then Patel spiral, a salvage procedure, Thompson. These are all Viva questions, these are rarely performed, and most of us would not have performed this. Hellstrom, and of course, endopyelotomy is usually commonly done in adults. Now here, I would just give you remember that the, this is actually, this is, Culp is actually curved actually. It is not a straight here and there is an error. Scardino is straight flap and this is C for curved flap. So you should familiarize yourself with, if possible, read the original articles and then build up on that. Also learn laparoscopic and the robotic approach. Now, please remember the 4 P's: pain, pyrexia, pyuria, palpability. These should be absent after a well-done pyeloplasty. However, you will be asked, how do you follow up? So you will say that you will perform an ultrasound and a renogram at the end of 3 months. And then, of course, these are the criteria. T-half within 20 minutes and decreased hydronephrosis. Remember, there can be residual dilatation. Then if this happens, if the GFR, split GFR is more than 30%, no further follow-up is needed. Maybe other than maybe an annual checkup for a couple of years, and then you can see off the child. Thank you very much for a patient hearing and for this wonderful opportunity. I hope I have saved some time. Over to Dr. Jnanendra and Dr. Arun.
Thank you, sir.
So thank you so much, sir. Thank you so much, sir, for an excellent case discussion. Sir, can I ask certain things on behalf of the students, because these are common questions in their mind?
Yes, sir. Yeah.
One is that is RGP mandatory before we undertake pyeloplasty?
No, RGP is not mandatory, because by and large, you have seen in practice that most of us do a DTPA renogram. Along with that, we have anatomical imaging, usually an excretory urography. So therefore, we are reasonably sure. And by and large, we don't see much of a pathology. Some Puritan examiners say, I would like to know the length of the narrow segment, which is usually not very long. And I think, all of us from practice will tell that there was hardly any occasion where we had to do anything other than Anderson-Hines pyeloplasty. This is the answer. It is not mandatory, but if it is done as a protocol, I don't think there should be. And my advice would be, don't roger the view junction during your manipulations. It should not be like something like a digging there, an archaeological expedition. Then anterograde stenting becomes a nuisance. And there are times when you have come out with the splint across the PUJ, because you let loose somebody to do RGP and there can be problems. It should be carefully, diligently, and neatly done. That is my advice.
Very true, sir. In fact, it's also my practice that I don't do an RGP, but if at all there is a need, I usually put a stent also at the same time, because otherwise an antegrade stenting is a very difficult affair later.
Yeah.
Sir, second query is that the latest edition of Campbell mentions that the T-half values are not indicative of presence or absence of obstruction, especially in children. This is an area of controversy. Each person has his own views. I follow a different dictum. Somebody else follows a different dictum. What would be your advice to students when they are interpreting?
My advice to students would be,
these are not well-tempered renograms.
No, my advice would be, let them now stick to the curve, that is washout curve, half time, and differential function till they pass the examination. But once they pass after they pass the examination, I would only say that it is the morphology of the PUJ which, confirms the diagnosis. You look at a PUJ, you know that this needs, that gut feeling comes from practice, but that cannot be uttered in the examination. In examination, stick to renography, because that is what it is now. And the guidelines also say that. And beyond that, one can be taking all the criteria, but it should not be that one should not insist that I need all the investigations, including MRI. That is actually a little overkill. As long as that balance is struck, I would say that let us not worry too much about the half time, but then definitely the curve And then, of course, again, there is an overestimation of this differential function. So I would go by the curve, the washout curve, and then be done with it. Thank you, sir. Anything else?
Yes, sir. Are the students expected to know the various grades of hydronephrosis based on the SFU grading, the AP diameters, and the Onens modification of the SFU grading?
I think what you said is SFU and Onens is actually no longer a nice to know area, it appears, because a couple of years ago, maybe half a decade ago, it was not considered, like even we kept on hearing about it in the so-called subspecialty circles, but now it is common knowledge. It is better for the student to brush up all these things. And that is why I was rushing through all this, but these cutoff values and the various gradings and whether the calyces are involved, they're not, all these things are probably essential now onwards. And one more point, that it is very common to find an upper tract dilatation in 1 in 100 fetuses, but a significant obstructive uropathy is only seen in maybe say 1 in 500, and out of which about 40% are PUJs. And finally, if you want to fix the incidence of or prevalence of PUJ, it will be more than 1 in 2,000 or 3,000. So every dilatation should not be jumped upon and offered an intervention. One has to exercise prudence and one should be restrained. One should be on a little careful back foot, and then of course follow up the child. Many points were where they mentioned about the 48-hour rule, so that's acceptable. But as you said, I think I would strongly recommend students, all the 4 and the rest, to read about SFU grading and Onens criteria. Thank you very much for drawing your attention to that. Yeah. And then, of course, a nice to know area is a biomarker like TGF, B2, and things like all those things have been estimated of, their suggestive obstruction, but they are now research tool as of now. I don't think they are into clinical practice. So once in a way, when you write a theory answer, you can, you can write it with the flourish, with some embellishment. That will fetch the candidate more marks. And that one-upmanship should always be there. One should know the nice to know areas also, because this is the highest level of examination.
Nowadays, it would probably, as you mentioned, in theory, they can also end up mentioning about cortical transit time and NORA values.
Exactly.
But again, not routinely accepted by a lot of people. So your advice, I think, is very well placed. That stick to the traditional T-half values, the drainage curves, for passing the exam, and once you are in practice, you go into the more intricacies of these things.
Exactly, because every day I think a day to learn something and pick up something or the other. So that goes on.
Sure.
Yeah.
We'll wind up.
Thank you very much. Thank you very much for this wonderful opportunity. Thank you, Amit, Pratik, Manish, and Shanti, and thank you, Navneet, at the central office. Thank you, sir.
Thank you so much, sir. Lakshman, sir. Chawla, sir, can we move on to the third case now?
Yes, without asking, sir, please proceed, sir.
Yeah. I think Shrenik Shah, sir, would be ready with the third case.
No, sir. If you see now we have Dr. Hemant. Dr. Shrenik is not.
Yeah. Hemant, sir, good evening.
Hemant?
Hi. Hello.
Hemant,
Yeah.
go ahead.
Hi, sir. I'm audible.
Well audible.
Yeah. Thank you, sir. Thank you for this opportunity. So I'll just share my screen first. Yeah. Thank you. I think thank you ISU and USI for this opportunity. And so the case is so there is a case of urinary incontinence in female. That is the case. Can you tell me who are the students along with me?
Navneet? Can the candidates introduce themselves? for this case? Case
We
number
have Dr. Saurabh, Dr. Chawar, Dr. Manoj.
Dr. Saurabh, Dr. Manoj, rest two are
Srish.
Dr. Sirish. And the first one is, sir, I think the first one was?
Dr. Manoj, Dr. Saurabh, Dr. Sirish. I think the fourth participant logged out accidentally.
Thank you. So we'll start with the case. Hi. So the case is basically, it's a very simple case. What I want to know is your thought process plus your knowledge also. But in the case of urinary incontinence, it's a thought process which is much more important than the knowledge. So it's basically a 36-year female. She presented with a complaint of continuous dribbling of urine with no normal voiding for 3 months. So I think Dr. Saurabh, so if such comes in your OPD with history of continuous dribbling of urine with no normal voiding for 3 months, so what comes to your mind?
So I would like to know more about the incontinence. Was there any previous history of any recent surgeries, or how is the incontinence? Whether it's continuous, whether has it increased?
What DD you have in your mind? Like if it's a continuous dribbling of urine with no normal voiding. So first, what DDs you have in your mind? What is your thought process in that?
Sir, it could be a VVF, sir. And next it could be a stress urinary incontinence. Or
a grade 3 stress urinary incontinence.
Sorry, sir.
Yeah, a grade 3 stress urinary incontinence can be there.
Yes. Yeah. The other would be a overactive bladder or a mixed urinary incontinence.
Yeah. So overactive bladder will not cause a continuous dribbling of urine.
Not continuous. Yeah.
So it can be a overflow incontinence.
Overflowing.
Okay. Yeah. So three things can be there: a overflow incontinence, a VVF. It can be a stress urinary incontinence. One more thing, it will be ectopic ureter, but that will not be for only 3 months. That will be from childhood.
That will be the longest.
Yeah. So very nice. So in this patient, there was a history of abdominal hysterectomy, which was done in January 2020 for dysfunctional uterine bleeding. Post-operative day 7, Foley was removed. Patient had urinary leakage the very same day. She was catheterized again. Foley was again removed after 3 weeks, but the leakage continued. There was no normal voiding in between. All past personal and family history, there were nothing was significant.
Okay.
So again, I think Dr. Sirish can answer, like what is again he's thinking about it.
Yes, sir.
Yeah, Dr.
Sir, I would expect some sort of injury near the ureter junction, possibly ureter vaginal fistula, sir, or vesicovaginal fistula.
Okay. So you are thinking of a ureterovaginal fistula and vesicovaginal fistula.
Yes, sir.
With there's a history of some surgery around 5 to 6 months back, and she's complaining of continuous incontinence of urine with no normal voiding. So okay. So probably you are thinking of vesico. Any other DD? Any other differentials?
Retrovaginal fistula also can be there, sir.
Retrovaginal.
Yeah. So your proximal ureterovaginal fistula can also is also a possibility. So it's probably a vesicovaginal fistula plus minus ureterovaginal fistula, because that is always associated in 10 to 15% of the cases of a vesicovaginal fistula, or a proximal ureterovaginal fistula, because a distal ureterovaginal fistula will not cause a urinary incontinence. Okay, it will cause more of a vaginal bleeding, but not a urinary incontinence. So that is there. So so it's a straightforward case. There's a history of surgery, patient causing continuous incontinence of urine. On examination, there is per abdomen, there is no organomegaly. Rest of the examination is normal. There is a vertical lower midline scar which is present. Per vaginal, there is a 1 centimeter rent palpable near the vault, approximately 7 centimeter inside the ontroitus. Margin of the rents are firm and smooth. Vagina capacious, no associated prolapse seen. So I think Dr. Manoj, can you tell me how will you proceed?
Yes, sir. Sir, we'll further investigate the case. We'll do urine routine culture, then CBC, KFT, viral markers, and then
So how will you do a urine routine culture? How will you do a urine routine culture in this patient?
Sir, we'll take a pooled vaginal sample. We'll clean the majora and minora, and we'll take a pooled vaginal sample, the urine sample, and then we'll send for routine and culture.
So that is very important because in this patient there is no normal voiding. Okay, so she is always leaking. So we don't expect urine routine or culture to be very sterile because sterile collection is not possible in this patient. So whenever you say a urine routine culture, you should be very, because in this the urine collection is itself not is a problem. She will not be able to collect urine. So a pooled vaginal sample can be taken, but it's not very informative. Okay, so this is a patient again, Dr. Saurabh. This is a patient who is who had a history of some surgery. She is having probably some genitourinary fistula. You are in your OPD, and how will you proceed? You have a small setup. You have a small examination center in your office. Cystoscopy is available. Everything like small setup. You are sitting. So how will you proceed in this case scenario?
So first, I would like to do an ultrasound, sir.
Okay.
Then after the ultrasound, based on the symptoms, if there is a cystoscopy available, I would like to do a cystoscopy. And I mean, first I would like to examine her, sir. I would like to first examine her.
Like what? Because why do you want to do ultrasound?
Sir, to look for the bladder as well as the kidneys.
So, like, how will that help in your diagnosis of a vesicovaginal fistula?
Sir, if you have to rule out UVF, I mean ureterovaginal fistula also, sir. There can be hydroureteronephrosis in that scenario.
So the first thing is important is the diagnosis, and then the sequelae of that disease you have to diagnose. So in an exam, you always have to first diagnose for what the patient has come to you. And second thing is you have to check for sequelae. The hydroureteronephrosis is the sequelae. Okay, so ultrasound is always an extension of examination, you can always say. But in this case, the patient is sitting in front of you. You suspect a vesicovaginal fistula. Dr. Sirish, any better thing which you can suggest to the patient?
So swab test can be done, sir.
Okay.
Triple swab test can be done with IV methylene blue or intravesical methylene blue, and we can ask it. Yes.
So, and Dr. Manoj, anything and what you will like to add in this? You will like to do a swab test or anything else?
Do IVU, sir.
Okay. So the thing is, you should always know that what you are looking for. Okay. The swab test, what is the, like Dr. Sri, what is the importance of swab test?
Sir, we can know whether the level of fistula is there, sir.
That we have already told in per vaginal examination, there is a rent 1 into 1 centimeter.
Okay.
Okay.
Sir, in this scenario, we can.
Yeah. Tell Dr. Saurabh, you can say.
Yes, sir. So in this scenario, we can go ahead with a cystoscopy, sir, and then do directly a CT IVU, sir.
Okay.
Because so already there is a rent visible in the cystoscope. So
very important part of the genitourinary fistula is a per speculum examination. Okay. So the patient, the history is very suggestive of a vesicovaginal fistula. Okay. Yes. Then you have to first diagnose whether there is a fistula present or not. Okay. You are sitting in your OPD, you can just do a per speculum examination. It will not cost you anything. Okay. You can just visualize the fistula. So very important is per speculum examination. That has to be done in all cases where you suspect per vaginal vesicovaginal fistula. It will help you differentiate between a SUI and a vesicovaginal fistula or a ureterovaginal fistula. Okay. Second thing is these swab tests, these methylene blue tests, all things are not very relevant in today's practice. They were relevant when cystoscopy was not readily available. So you would not have seen a swab test in your department in last 10 years. Okay, so the commonly thing what we do is a good history, a good per vaginal examination, per speculum examination, and when we have diagnosed the VVF, we do a good cystourethoscopy. Okay, we don't need any further investigation in otherwise straightforward case. So that you should take care. These all tests, the fancy tests, they were present when the cystoscopy was not readily available. Now office cystoscopy is available to all of us. Okay. So next, what will you do?
A CT urogram, sir.
No. Again, see, the important is the thought process. Why do you want to do a CT urogram? Why do you want to do a CT urogram?
Sir, to rule out a ureterovaginal fistula, sir.
So first you have diagnosed vesicovaginal fistula.
Yes, sir.
So
Cystogram, ureterocystogram is done, sir. So in that there is a rent. So
you will do a cystoscopy first, or you will do a CT urography first?
Cystoscopy, sir. Cystourethropy.
So cystoscopy, you should first say that I'll do a good cystourethropy first. Okay, yes, and then you will decide whether you need a CT urography or not.
Yes.
Very important in the case of genitourinary fistula. When you are into practice, this is very, very, very important. You need CT urography or IVU on only 10% of the cases. I'll tell you, you'll come to know later on. So on a per vaginal examination, a 1 centimeter rent was palpable. Some basic investigation was done in the form of urine routine microscopy culture. Again, I have put a question mark because these are not very reliable, because there will be some pus cell, there will be some WBC, because it is a pooled vaginal sample. It is not a sterile sample. CBC, serum creatinine were all normal. This was the ultrasound. Again, it was normal. Okay, so then we just come to, this is something, cystoscopy. So next, I think you all agree that after this, in a straightforward case, we'll go to cystoscopy.
Yes.
Yeah. So in a cystoscopy, it was a external urethral meatus was normal, urethra was normal, bladder neck was normal, bladder capacity was normal, bilateral ureteric orifices were visualized, their efflux was clear. There was a 1 into 1 centimeter defect noted just above the interureteric ridge. Vaginoscopy, again, the 1 into 1 centimeter defect in the vault anteriorly was present. This was the cystoscopy image where they're saying a small fistula in just above the interureteric ridge. So Dr. Saurabh, now what is your further plan?
Sir, I would like to know the area of the fistula, sir.
So the fistula is just above the interureteric ridge in the center, in the bladder. In the vaginal area, it is 7 centimeters from the introitus near the vaginal cuff.
Sir, the CT urogram, I think it was, I didn't see the report, sir. If it was suggestive of vesicle.
You need CT urography now?
So it is required, because just to rule out
Dr. Shirish and Manoj, any difference of opinion, or you agree with Dr. Saurabh? Dr. Shirish, Dr. Manoj?
If the both ureters were, if the ureters were not dilated, sir, in ultrasound and CT, so that means the ureterovaginal fistula has been ruled out. So now only there is supratrigonal 1 centimeter BVF.
So that is the point actually. When you do a good perspeculum examination and you do a cystoscopy, I have mentioned, you see for both the ureteric orifice, there is a good efflux from the ureteric orifice. You just need any upper tract imaging, ultrasound also, if there is no hydronephrosis, that rules out ureterovaginal fistula. You have done a vaginoscopy, there is only single end, you put a guide wire, it will come from the bladder. In this case, you don't need any CT urography or IVU. So CT urography and IVU is only required when you suspect ureterovaginal fistula. In this case, you don't suspect ureterovaginal fistula. Okay, I think Dr. Saurabh, you got my point?
Yes, sir, yes.
Okay, so in this case, we don't need IVU. We don't need, in this case, otherwise a stable, uncomplicated vesicovaginal fistula, only perspecular examination, cystourethropy, and some upper tract imaging in the form of ultrasound, CT uro, or IVU is sufficient. Even ultrasound is sufficient. So in this case, ultrasound is sufficient. Otherwise, for the reference, I'll just show you the MCU image, because in this case, it was done. The patient was evaluated outside. This is a lateral image, where we can see a vesicovaginal fistula, and also CT, we can see a ureterovaginal fistula as well as VVF. So I think we'll go forward. Dr. Manoj, Dr. Shirish, how will you go ahead now? Will you operate the patient now? It's suppose the surgery was 3 months back. You'll operate him now or her now, or you'll wait for some time?
Yes, sir.
Dr.
She was operated in, I think January she was operated on, sir. It's already now 6 months, I think.
Okay. So how you decide whether this is the right time to operate? Suppose it was 2 months back. Suppose it was she was operated. She had an injury 2 months back. So how do you decide whether it is the right time to operate or not?
All the gynecologists,
yeah,
sir, which means ultrasonic fistulas, they should be operated at least after a period of 6 weeks, so that the stormy means post-op period is resolved and all the fibrosis and the inflammation is subsided, and means that's the best time to means go again and do the fistula. So at least we should wait for 6 weeks, and we can repair, sir.
So it's only the time period is fixed because conventionally it is said that you should wait for 3 months. Okay, but the problem is on cystoscopy, the patient want to get rid of this urinary incontinence as early as possible. So she'll come and say that please operate me after 1 month. So will cystoscopy help you or not, or a vaginal examination? Can you decide you can operate early, Dr. Manoj?
Yes, sir. In the cystoscopy, the fistula's tract, if it is mature, the mucosa look healthier, then we can go ahead, sir.
That is very nice, very valid point. On a per vaginal examination or cystoscopy, if you think the fistula is mature, there is no evidence of infection, there is no evidence of skin excoriation, the fistula is mature, it is a distinct ossia which you can make out, there is no bullous edema, the vagina is capacious, vaginal mucosa is healthy, you can operate even after 6 weeks. But conventionally, you wait for 3 months. So that is one thing, is timing of the surgery, early or late. Second thing is which route, Dr. Saurabh, how will you like to proceed? You'll do a abdominal repair or you do a vaginal repair?
Sir, in this patient, I think vaginal approach would be, because it's near the introitus, so it's I think 5 centimeters. So vaginal approach would.
So if it was 2-3 centimeters above the introitus, then like inter-ureteric ridge, then like in which case you will do a abdominal repair?
Sir, if it's a very high fistula, sir.
Okay. So the Dr. Shirish, any other answer? In which case you will like to do abdominal repair? 2 or 3 indication?
If it's a uretero, I mean, if it's a combination of a ureterovaginal fistula, and if it's a high fistula, and if the introitus is very narrow, then abdominal approach would be.
Dr. Saurabh, there are 3 or 4 indications for abdominal repair. One thing is, the most common indication is the surgeon is does not have expertise in vaginal surgeries. That is the most common indication of abdominal repair. Okay, because he doesn't know how to do vaginal repair, he'll do abdominal repair, which is equally good. There is no problem in that. Second thing is when we are contemplating a ureteric implantation. Okay, so to do that from the vaginal side is very difficult. Third thing is when there is a small bladder capacity. Sometimes female come to us after 5 or 6 years of large vesicovaginal fistula. So the bladder is contracted. You have to do a augmentation cystoplasty along with that. In that case, you have to do abdominal repair. And the fourth indication is when the multiple failed vaginal repair have failed. So these are the indications of abdominal repair. Otherwise, you can do all repair from vaginal. Okay, and especially in a post-hysterectomy fistula, because this patient had hysterectomy, you can do even dome fistulas you can do from vaginal side, because you can just pull the vagina and bladder into the operative field. Okay, so a post-hysterectomy fistula is easy to repair vaginally rather than a post-cesarean fistula, because a post-cesarean fistula, the uterus will be there. It's difficult to pull the fistula into the operative field. You got my point?
Yes.
Okay, so probably I think you'll repair it vaginally. Vaginally. Yes, so Dr. Manoj or Dr. Shirish, how will you go about it? Our transvaginal VVF repair. Which technique you will use? Can you tell me some repairs, transvaginal repair?
Hemant, 5 minutes left, Hemant.
Yes. Can you tell me some transvaginal repair?
A flap.
Okay, just tell me. Okay, I'll tell you. There is let's go repair. There's RAS repair. So let's go repair is generally used for a post hysterectomy high walled fistulas. Okay, and for an intervaginal fall fistula, we use RAS repair. The most important part of the repair is you know, it is a multiple tension free multiple layer tension free repair.
Yes.
That you know. So that's the most important layer. The first layer is the bladder. The fibrotic ring which has to be closed. What is the second layer? That is the most important layer, in which you take perivesical tissue.
Perivesical. Yes.
Okay, so that perivesical and a deep musculature of the bladder, that comes in the second layer. A good second layer is always very important for a successful VGF repair. In which cases you will use an interposition graft. Just my last one or two question. Interposition graft.
Yeah. So usually in vaginal repair, the normal graft is Marsh's graft, sir. So Marsh's flap basically. So in cases where is the
is it required in all cases?
No, sir. If it's a complicated case with complicated obstetric cases, or if there was a history of radiation, and if it's a recurrent VVF, and
so very, very nicely said. It is not required in an uncomplicated simple VVF, but it is required when the tissues are not very healthy. If it is a recurrent VVF, if there is a associated infection, or basically in that cases you need a interposition flap. Okay. Yes. So if it is a radiation fistula, in complicated fistula, you need an interposition flap. Important is a Marsh's flap can only come till the anterior vaginal wall. If it is a walled fistula, it is a very high fistula. You have to make use of omentum or peritoneum.
Omentum or peritoneum.
The Marsh's flap will not go till the dome of the bladder. Okay, yes. So that is very important. Post-operative, you have just repaired it. Post-operative, how will you take care of the patient? What specific instruction you will keep? You will keep the catheter for 10 to 14 days. Any about sexual activity or anything you will give the advice to the patient?
Sir, to avoid sexual activity for 4 to 6 weeks, sir. And before before the catheter removal, to do MCU, sir, to look for.
Again, that is not required in all the cases. You just require it in a complicated case, but routinely we don't do any pericatheter study in a otherwise uncomplicated BVF. So two important advice is you avoid sexual activity for 3 months and you avoid conception. In this, it is a post-hysterectomy, but if it is a post-cesarean, you avoid conception for 1 year.
Yes.
Okay. I think that with that, we can, if you have any question or we can, because the time is up. Hopefully it was informative.
I just wanted to ask, sir, in guidelines, I think they've mentioned CT urogram is mandatory, EAU guidelines. So.
No, it is not mandatory. It is never mandatory. Only thing mandatory is a good pulse speculum examination and cystourethoscopy. Rest all are optional. You will see Campbell also, they are all optional. IVU, MCU, CT urography, they are all optional. A good pulse speculum examination and a cystourethoscopy is what is essential. Okay. Yeah.
Hemant, excellent discussion. Thank you very much. Dr. Gyanendra, please take over.
Thank you, sir.
Thank you.
Thank you, Hemant, for completing it on time. Our next case will be presented by Dr. Ranjan. He is the professor and head of Department of Urology at Indira Gandhi Institute from Kolkata.
I am from Calcutta, Ajikor Medical College. Thank you very much for the introduction. I don't want to waste time, Dr. Chawla. Thank you very much, Dr. Gyanendra. Now, I want to make the presentation very simple as it is come and asked in the examination. I just like to know what the students who are going to face it.
Sir, we have Dr. Divya, Dr. Arnav, Dr. Malesh, and Dr. Chawar.
Dr. Chawal.
Chawar.
Okay. So there are 4 candidates for this today's examination. So we are going to start our presentation. Next slide, please. So is female, 67 years of age, presented with pain in the right side of the abdomen for the past 3 years. And she's also having pain during the urination for the 2 years. So with this little presentation, don't change this, don't give this. With this small presentation, what are the things you would come to your mind that you further want to know from the patient, Divya?
So pain is intermittent or continuous, associated radiation, any associated history of fever, and lithuria or hematuria, and the history of hematuria or lithuria.
Next slide, please. Next slide. You see, the pain was insidious in onset. It was dark-looking in nature. It was intermittent, not radiating, not associated with fever, nausea, vomiting, and not associated with hematuria. The questions you have asked, going to ask, everything is being answered in this slide. So I like to know what is the importance of this insidious onset and dark-looking pain in a patient like this?
More of a renal pathology rather than a ureteric pathology, yes. And more of a chronic, yes, more of a chronic pain rather than an acute pain.
Yes, very good. That means the patient is having some pathology in her kidney for some time, for which the insidious onset, there was no acute episode, there was no associated other fever, nausea, vomiting, all these things were present at the time of presentation. So after this, what is your next question to the patient? Arnav? What is Arnav?
Sir, yes, sir.
Yeah.
Am I audible?
What will be your, yeah, you are audible. What will be your next question to the patient, or what information you want to have from the patient?
Sir, I would like to know from this patient whether she had any past surgeries or not.
That means you want the past history of the patient.
Yes, sir.
Yeah. Anything else? Anything you want to know about the patient apart from past history, past surgical history? Try to think. It is your exam. I'm going to teach you. I just want to tell you how it is the examination you are going to find. If you can't answer, Dr. Malesh, can you answer what else you can ask for?
Yes, sir. Good evening, sir. Am I audible, sir?
Yeah.
Yeah, sir. I would like to know the comorbidities of the patient, like any diabetes, hypertension, whether there is any past medical history or past surgical history, and is she on any medication, drug history? I want to know, sir.
Good. Very good. Very good. Anything else?
This much I would like to know, sir.
Okay, you will not. Yes, whether she is having recurrent urinary tract infection, whether patient is having voiding dysfunction, because at the beginning I have said that she is having pain during urination. So these are the points you should inquire from the patient. Next slide, please. Next slide. Yeah. Patient develop pain during micturition, associated with burning urination, associated with frequency of urination off and on, and past history of ESWL on the left side. Past history of ESWL on the left side. So with this information, what is your primary thinking that this patient may have this kind of a pathology?
Sir, I will think of a stone disease. So can be a VUJ cancer, which can present with a flank pain as well as
louder, please. You are thinking of stone disease in
distal ureteric calculus or a VUJ calculus.
You are thinking of distal ureteric calculus or VUJ calculus? Achha. And I just like to know, in VUJ calculus, what is the common presentation? Is it the pain in the back?
Colicky type of flank pain with radiation.
Yes, it's a colicky type of pain with radiation. Yes. So with this history, Dr. Chawar, next slide, please. Next slide, yeah. This is the information you people were asking for. I have provided that the patient is hypertensive for 10 years. Rest of the things, there is no positive important presentation in the history. You can look into it. Don't want to waste time because many things to be discussed in short period. So she's a postmenopausal woman with no specific comorbidities and at high only excepting hypertension. There is some sound, background sound. Please stop it, whoever is doing it. Yeah. So next slide. Next, what is your next requisite? What do you want to know? This patient, Divya.
Any history of instrumentation is not mentioned here, sir. And urinary stream also I'd like to ask for the patient.
Patient is having a normal urinary flow, but there is pain during urination, occasionally off and on with frequency. Nothing more information can be gathered from the patient on inquiry. So next slide, please. Next comes the examination. So I am not wasting time in general examination. In specific, what examination, what are the things you want to see specifically apart from the general examination in this patient, Dr. Chawar. Dr. Chawar?
Yes, sir. I am audible?
Yeah, you are audible.
Okay, it is not adding anything into diagnosis, sir. Because general and
I cannot hear you. Bit louder, please.
Yes, it is the examination part is not adding anything more to our diagnosis, sir.
You will not go for examination of a patient who is presenting to you pain abdomen.
Yes, sir. We would like to see the renal legal gentleness, any renal legal fullness, and he had history of dysuria, so we would like to palpate the bladder as well.
So, Dr. Malesh, do you have anything to add in the general examination which you should do for?
Yes, sir. I would like to do the parabdominal examination.
Yes. Actually, in the examination, come to the point you are appearing for the examination. You will have to say, start from the inspection, then
Yes,
palpation, then come to other evaluation. It is needed. Just because it is a super consultancy examination, you cannot omit the basic steps. Never forget to mention in the examination the inspection and palpation. So in inspection, you want to do a inspectory finding. You want to give followed by palpatory finding.
Yes, sir.
Isn't it? Yeah. Show me the next slide. Next slide, please. Can I do this? Next slide, please. Dr. Chawla, next slide, please. Yeah. So there is nothing positive finding in this present. In this palpation, inspection and palpation, there is no positive finding. So with this thing, now I am asking you, what is the provisional diagnosis? First, you tell me what are the differential diagnosis of this condition. Dr. Arnab, you tell me what the differential diagnosis of this condition.
Differential diagnosis which I would consider is first I will think of stone disease. Next I will think
little
of
louder, please. Louder, please. Bit.
First I will think of stone disease. Second I will think of infective causes. Like chronic pyelonephritis.
Very good.
Third, I will think of malignancies, whether it's a renal cell cancer or not.
Yes. These are the very important three differential diagnoses you should consider. Very well said, Arnab. Divya. Next, what investigation would you advise to this patient? With this, after the examination, you will have to write the investigations so that you come to a conclusion. What will be your investigation?
Urine routine, urine culture, and X-ray KUB.
Nothing else. You will have to see other things also.
Hemoglobin, total count platelet, creatinine.
Routine blood test. Routine blood test, renal function test, and other blood sugar and other things you will have to see. I will show you the next investigation. Next slide, sir. So this is the investigatory report of this patient. See, quick. Now
grossly, it's normal.
So
it's
I have put two questions. Can you see? So what else do you also should get? That is why I kept the area blank for you.
Urine routine is not mentioned.
No, it is blood investigation I'm talking about. Urine routine you will get. In the blood, what else do you like to add for this patient? Which
serum calcium, phosphorus, and
serum calcium. Exactly. Serum calcium is a very important parameter. Dr. Arnab, what is the normal serum calcium level in adult patient?
It varies between 8.5 to 10.5, the corrected calcium level.
Corrected calcium level is 9 to 11 or 8.5 to 10.5. This is two things. Always remember, because the subsequent questions and subsequent presentation will depend on this. So this is the thing in calcium you will have to take into consideration when definitely there is a history of stone disease in the past which was treated by ESWL. Okay, so apart from this serum calcium, if the serum calcium turns out to be high, suppose serum calcium turns out to be high, it is 11.5. What further?
Serum parathermal.
PTH. Serum parathermal. PTH you will have to consider. Next slide, please, sir. So this is the urinary investigation you were looking for. This is the urinary investigation in this patient. Have you seen?
Yes.
So is there any positive finding, or you want to look for any other addition in the urinary investigations?
So if the characterization of the crystals can be done or not, that what kind of crystals are there?
So what, I could not hear you. What kind of?
Sir, crystals can be classified because it shows urinary crystals are there. So based on which we can also identify which kind of crystals and what we are dealing with.
Actually, very importantly, it has, yes, that's what I was asking for, that the serum urinary pH is very important if you suspect a stone disease, because the pathogenesis of many urinary system stone disease gives an indication start from the urinary pH. So pH should have been considered in this report. Next slide, please, sir. Sorry, put it back, sir. Please go back to the previous one. Now you tell me what do you want to have as a further investigation for this patient. In this patient, the serum pH is 7.21. 7.21. Okay. So what else you want to do in this patient? Further? Dr. Chawar, you are very silent. You must answer. What investigation would you advise in this patient? Dr. Chawar, please unmute.
Yeah, sir, we will go for further imaging test, sir, based on X-ray QB.
Yes, X-ray QB
and that modern era, sir, we will go for CT urogram, sir.
You want to go X-ray QB and CT program. Any other option you want to do? You want to have X-ray QB is a definite indication, but any other investigation, Divya?
Ultrasound, abdomen and pelvis.
Ultrasound. So what ultrasound will you advise?
Abdomen and pelvis with the PVR.
Yes. Always say abdominal ultrasound. Never say ultrasound QB. You know, because there may be many other associated pathologies which can be sorted out during this basic investigation. So we have also advised, as Dr. Chawar said, X-ray QB, and Dr. Divya said ultrasonography. Next slide, sir. Next slide. So this is I'm giving a very small presentation. So this is the ultrasonography of the right kidney, and this is the ultrasound of the left kidney. We'll look at it and give you a small opinion. Quickly, Dr. Arnab.
So in this ultrasound, the left kidney parenchyma and the echo texture appears normal.
Okay.
And on the right kidney, there is a stone, most probably in the lower pole, with mild hydronephrosis, with a maintained parenchymal thickness.
What is the normal parenchymal thickness?
At least 1 centimeter in an adult.
1 centimeter. Any other opinion? What is the normal parenchymal thickness?
Around 2.5 centimeters, 2.5 to 3 centimeters.
Yes. Divya, you are very smart. You are looking at the thing. And
less than 1 is considered.
Yes. So it is 2.5 and above is the normal this thing. Anyway, this is in this ultrasound. When you will read ultrasound, you will have to speak about. You will have to say about the margin of the kidney. You see in the left side the margin is little irregular. You can make out. On the right side, the margin is clear, but there is obstructive changes in the kidney. There is hydronephrotic changes in the kidney. So with this background, now you have come to conclusion that patient is having the stone disease. Till now, the diagnosis is recurrent stone in the right kidney, isn't it? Okay. Next slide, please. So this is the answer of your ultrasonography. You can say this is the largest measuring is 16 centimeter. All these things are there. Next slide, please. Next slide, sir. So this is the X-ray what Dr. Chawar you have asked for. So looking at this, please read out this X-ray.
So this is a well-done X-ray baby, exposed from situation to lower border of pubic symphysis.
Little louder, please.
So this is a well-done X-ray QD, well exposed from lower border of GP right down to the lower border of pubic symphysis, and that other body structure are normal. There is one large branch radiopaque shadow in the lower pole of the right inner region at the level of L2, L3 level. That is the ratio of partial second calculi.
So, Dr. Arnab, can you describe this X-ray in a little better way in the examination? The presentation, this you are learning from your third year, how to present an X-ray QB. What are the things you must mention in X-ray QB?
So we have to mention whether this X-ray was done in the erect or supine posture. So erect X-ray with the AP view of the has been taken, anteroposterior view.
Yes.
This is underprepared and exposure.
Underprepared with some amount gases are there, and it extends from the lower part of the thorax to the pelvis, including the pelvic bone.
Okay. You have to mention, listen, you will have to mention of the bony consideration of this patient, and also the density of the stone in relation to the bone. Also the density of the stone. Look at the density of the stone. So looking at this stone how do you describe this? What is the classical description of this stone?
Hard stones. Hard stones with the
It's a staghorn calculus. So in now, and the density is more than your bone.
Yes.
So what are the possibility? What is the chemical possibilities of the chemical composition of this bone?
Calcium, ammonium, magnesium, phosphate, sir.
Unlikely.
Struvite stone.
Yes, sir. Struvite stone.
Any other thing?
Calcium oxalate, sir. Calcium oxalate, monohydrate or dihydrate.
Calcium oxalate, monohydrate or dihydrate. Very good. So if it is a calcium struvite stone or the calcium struvite stone, so what precaution, what will be the planning, and what will be the you have to counsel to the patient, because she is a recurrent stone former. What further investigation you like to do, and how will you counsel the patients? Briefly, Divya.
I'd like to obtain a prior urine culture. In this patient, it was normal. Then I'd like to also do a stone analysis for the patient in the post-op period, and a surgical approach would be more preferable in this case rather than a minimally endoscopic approach.
So are you talking about the open surgery you are talking about?
No, PCNL would be more preferable rather than a ESWL or a
ESWL. What are the indications of ESWL? How up to how much you can do?
Less than 1,000 Hounsfield units, and
size?
Size lower pole stone less than 1 centimeter, and upper pole and mid pole less than 1.5.
So looking at it, what do you think? It is 1 centimeter.
No, here we can't.
You cannot think of ESWL or anything. But what is important in this case, what you should have to consider, because if it is a struvite stone, it is an infective stone.
Yes,
so what is very important in this patient for the treatment, Dr. Chawar? What special care or special step you will take complication in the management of this patient? I think there is some problem with Dr. Chawar's.
Antibiotic coverage prior to the surgery.
Yes, prior antibiotic coverage to give it. But before that, just I will discuss all this. I will discuss all this. Just you tell me, after you get this, any further investigation do you want?
Yes, sir.
Yeah, tell me what.
Sir, I will go for a CT urogram with delayed phase images. So which will help me to both plan my surgery and my approach for this patient, and also it will tell me about the function of the kidneys also.
Yes, yes, very good, excellent. So CT urogram is the next line of management. Acha, is there any other option apart from CT? Suppose you are practicing in a remote place where CT facilities are not available. So can you advise any other investigation?
So I can do IVP.
Achha, just you tell me what are the advantages of CT urogram over IVP? Just in 2 points, you have to tell me.
The CT urogram tells about the calicial anatomy.
Yes.
No. And it also tells me about the Hounsfield unit of the stone, which means how hard the stone is.
Yes. Anything else? Any advantage? Major advantage? Yes. Yes. Number 2. Number 3 is that any associated pathology outside the kidney. Number 4, the special gut preparation is not necessary. So next slide, please, sir. Next slide, please. This next slide, please. Then I will come back. Achha, let's stone. So we have go back to the previous investigation, sir. Yeah. So these are the basic thing I just want to convey. Remember these are the very commonly asked question. What are the radiopaque stones? What are the radiolucent stones? Or what are the percentages of the radiolucent stones in this group? We have seen it. So I'm going to the next slide. Next slide, please, sir. Any other investigation you want to do in this patient? Divya has said one, but apart from this, any other investigation you want to do, especially in a recurrent stone former?
Along with calcium, serum phosphorus and uric acid, sir. Serum uric acid.
Uric acid.
And, yes. And 24-hour urinary analysis
urinary.
after stone is cleared.
No, you don't want to do 24 hours urinary calcium. You don't,
yes, sir.
Don't
Once
want
the
to
stone
know
is
whether
cleared.
it is. No, that is different. That is different. 24 hours urinary stone assessment should be done because that will give you the clue that whether patient is having hypercalciuria or not. Okay. So next slide, please, sir. Next slide. So these are the list of the investigations which you should do, but out of which in the clinical practice, you will have to choose 3. Tell me what 1, 2, 3, what will you choose in this group for the day-to-day clinical practice? In a recurrent stone former, the very hard stone in the X-ray, what will you do? Quickly.
PTH, uric acid,
yes.
And phosphorus.
Yes, very good. Next slide, please, sir. Next slide. So, what this is the information I want to pass. Remember it. This is very commonly asked. What do you mean? What are the normal urinary calcium in 24 hours? Yes,
a little more than 5 minutes left. Ranjan, can you little
okay,
hurry up?
okay.
Yeah.
I'm going fast. I'm almost finished. So these are the things you must take into consideration. Next slide, please, sir. Next slide. So this is the CT urogram. Next slide, please, sir. Read out quickly. Dr. Arnob, read out quickly. Only 5 minutes left. I will have to finish.
There is a large pelvic stone on the right side of the kidney, involving the calyces, mostly the middle and the lower pole calyces. And
next, please, sir. Next slide. Next slide.
Parenchymal thickness is good. Parenchymal thickness is good, sir. And other than that, no retrorenal colon I could make out.
Okay,
and
very good. Very good. Next slide, please, sir. This is reconstructed CT urography. Okay, so with this, what is the management plan?
Sir, I will go for a percutaneous nephrolithotomy. Maybe staged procedure may be required.
You are going for percutaneous nephrolithotomy.
Maybe staging of the procedure.
Staging of the thing is required. Okay, okay. So precaution, you have already stated that you have to put the patient on antibiotic. And what calyx would you like to puncture?
Lower calyx.
So in this field, I will go for mid-pole posterior calyceal puncture.
Mid-pole calyceal puncture. What is the problem you can face in this particular type of patient while you are doing PCNL? I know puncture will be very easy. Puncture will be very easy. But what will be the major problem you can face in this group of patient?
So one of the calyx stones in the lowermost part may not be cleared with the one puncture. So we may have to do a staged procedure at a later stage.
Or 2 punctures, or maybe 2 punctures may be needed at the
multiple punctures may be needed to clear. Yes. And it is already being said that suppose PCNL facility is not available, what will you do?
Pyelolithotomy with the extension of the.
Do you think Do you think it is possible to do pyelolithotomy? That is the question I am asking you. Is it possible to do pyelolithotomy in this patient? Sir, 2-3 minutes more. Is it possible to do pyelolithotomy in this patient? No. So what will you have to do? What are the types?
Anatrophic nephrolithotomy.
You tell me what are the types of nephrolithotomy in 2 lines. One, you have said anatrophic nephrolithotomy posterior along the broadest line. What else? Anterior radial along the branches of the renal artery, so that the chances of injury to the renal artery is less in this patient. Next slide, please. Next slide, please, sir. Next slide. And in this particular case, you can see, make out that the stone has occupied almost the 2/3 of the pelvic calyceal system. In my opinion, if you want to do, you have to warn the patient very carefully that residual stone may be there, and the danger of this residual stone is the recurrence of the stone. Next slide, please, sir. Next slide, please. There you can see the details of it. Next slide, sir. Management options. So management options I have given. So now you tell me, Dr. Chawar, can you tell me what you have done a fantastic job. How will you advise the patient in the post-operative period how to prevent further stone? And stone analysis is very important in this case because it is a stone recurrent stone former. To tell me just what advice you will give to the patient.
We will advise first proper adequate hydration, sir.
Anything else? Dr. Arnab, you want to?
Sir, I will call the patient after 4 weeks for a 24-hour complete metabolic workup.
Yes.
And also, since she is a recurrent stone former, I will also inform her there is a chance of recurrence in the future. So she needs to follow up with an annual X-ray TB as well.
Okay. Anything, Malesh, you want to add?
Yes, sir. Like general, I want to ask the patient to have adequate hydration, and so that she can produce about 2 liters of urine every day. And food, I want her to take moderate calcium intake. And after 4 to 6 weeks, we would like to get the 24-hour urine analysis, sir. And based on that one, further management, I would like to advise the patient.
Okay, Divya, you want to add one more line? Anything you want to keep? Yes. Anything you want to add? Who is this Ankit? Okay. Anything you want to add for patient?
Diet modification along with the...
Apart from this infection, you will have to prevent it first because these patients are usually having recurrent urinary tract infection, mainly Proteus, Klebsiella, and Pseudomonas. So we will have to be very regularly in consultation with the patient to prevent further urinary tract infection and keep it sterile. And I think the time is over, sir. Dr. Chawla, sir.
Yes, Dr. Chawla, sir, it's over, sir. Yeah, thank you very much, sir. Thank you. We'll proceed with the.
Thank you. Thank you very much. Thank you very much, sir. Thank you all, my sir.
Rishi.
Thank you, sir.
Yes, yes, sir. So, shall I start?
Yeah, go ahead, please. Can you give the two PG's names?
Yes. Sir, we have Dr. Tushar, Dr. Aditya, Dr. Shruti.
Okay. Thank you.
Over to you, Rishi.
So, Dr. Tushar, Dr. Aditya, Dr. Shruti, good evening.
Yes, sir. Dr. Suman.
Can you see the slide, sir? Hello?
Yes, sir. The slide is visible, sir.
Yes, sir. It is visible.
Slide can be seen. Yes, sir. Visible.
Okay. The slide is not moving. Okay. So I'll go straight to the case in interest of the time. We have this 42-year-old male who presented to us with hematuria, which was intermittent, painless, gross, total, and with occasional clots. And this hematuria happened 4 years back. And now he complains of a recurrence of hematuria for last 3 months. He's a smoker and a street hawker by profession. So what do you want to ask in this patient? Dr. Tushar?
Yes, sir. Sir, I want to know any other urological complaints like lower urinary tract symptoms, then any abdominal complaints like flank pain, or any constitutional symptoms like fever, or any other symptoms, constipation, or any other symptoms.
Okay, so by asking about the lower urinary tract symptoms and pain, you want to localize the site of hematuria.
Yes, sir. Yes, sir.
What we know is there is a definitive urological pathology there, and
Yes,
by
sir.
doing that, we want to localize it. Okay.
Yes, sir.
So, Dr. Aditya, anything else you want to add?
No, sir. I think so.
So, what diagnosis you have in your mind with this history, brief history that we have taken as yet?
Yes, sir. Sir, based on this brief history, one suspicion would be, I would first like to know about flank pain and lower urinary tract symptoms. If
there
just
is no
this
flank
history is
pain,
given,
patient,
then I would
is
consider a bladder or history of bladder stone as my differential diagnosis.
So why do you consider bladder stone as a first differential diagnosis?
So bladder stone would be the third differential diagnosis. First one would be bladder malignancy. The other would be stone, upper tract stone, that is renal stone. Third would be bladder stone. The reason being that he's a young male, and initially he had hematuria early 4 years ago, at which time the stone may have been small, and as it became bigger over the last 3 months, he has started to have hematuria.
Okay, so
the reason for putting it third is that the duration of the symptoms is quite prolonged.
Yes. So here we actually need to go more in detail rather than just limiting ourselves with this much of a history. So when we ask the past history, the patient gives a clear-cut history of having undergone a surgery, most likely TURBT, 3.5 years back, and he does produce a discharge paper with him, which shows that there was a 3 into 3 centimeter growth at the right VUJ, and the histopathology of it was T1 high-grade disease. And he was advised intravesical therapy, to which he did not comply, and there are no other known comorbidities. Okay. So as regards the complete history, we need to actually ask about bleeding from any other sites also, the predisposing factors which may have predisposed him to develop urethral tumor, urinary tract tumors, like the prolonged use of analgesics. And then we also need to actually complete the history by asking about whether the patient has nausea, vomiting, facial puffiness, breathlessness, all the signs of which may actually be present in a CKD patient. And there is no similar family history. Dr. Shruti, why is family history important in such a patient?
So there are certain hereditary transitional cell carcinomas. So that's why family history is required. So for
which form of transitional cell carcinoma would be hereditary?
Lynch syndrome is associated with hereditary upper tract transitional cell carcinoma and lower tract as well, sir.
Yes, good, very good. And why do we need to ask in more detail about the smoking history?
So we need to know the pack per year consumption, because the longer the duration of the tobacco chewer or cigarette smoker, that is directly proportional to the risk of bladder transitional cell carcinomas.
Supposingly, if he says that he had been a chronic smoker and is now reformed for last 10 years not smoking, then does his risk of developing tumor remains the same, or is it now is it equivalent to the normal non-smoking population?
So it remains the same, sir.
No, the risk actually remains higher than the general population, but it gradually decreases.
That's why I'm asking.
Yeah. So, what will you like to examine in this patient, Dr. Aditya?
Sir, I would
just give
like
me the specific examination points that you want to see.
Sir, I would like to examine in the porabdomen findings. I would like to see if the bladder of the patient is palpable or
not. Let's go stepwise. Any specific general physical examination findings that you would like to highlight?
Yes, I'd like to look for anemia. I would like to look for whether the patient has tachycardia or not, which may be a presentation for the anemia. I'd like to check for lymphadenopathy, and then I would like to go on to the systemic examination, where I would like to check whether he
in
has a
general
palpable
examination, see here from history, the diagnosis is pretty much clear that we are dealing with the case of transitional cell carcinoma of the bladder, okay, which has probably now recurred after about 4 years.
Yes.
So in examination, you have correctly said we need to look for pallor, presence of any edema, lymph nodes, but simultaneously in any oncological case, we must also look for the general build of the patient, and it would always be better if you can comment upon the frailty status of the patient or the performance status of the patient. Okay.
Yes,
sir. So these are important for deciding the treatment subsequently.
Yes.
The abdominal examination was unremarkable in this patient, and the rectal examination was done, which showed a prostate of grade 1, firm, non-tender, and there was no mass palpable. So anything else that we can comment upon, Dr. Tushar?
Sir, I want to know the other system also. I want to know the respiratory system. I will know whether there is any air entry decrease in bilateral lower or any.
So we need to comment upon at least the chest
respiratory system, and yes, I want to know all systems, but particularly respiratory system.
But limiting ourselves to the DRE, it is always better if you, while doing a DRE, you also do a bimanual examination and just try to find whether you are able to palpate it bimanually. Sometimes what happens is a soft tumor may not be palpable with a single finger, but when it is compressed from above, you may be able to bimanually palpate it. And bimanual palpation also gives additional information in terms of the extent of disease. DRE per se may not be able to give as much information. Okay.
Yes.
So let's come to the diagnosis. As I said, is pretty clear. Probably the first diagnosis would be recurrence of bladder tumor. What other differential can be there here?
Sir, metachronous lesion in the upper tract, that is the ureter or the renal pelvis.
Yes, very good.
May have happened.
What percentage of patients develop upper tract metachronous tumor?
2 to 4% of patients with a previous lower tract malignancy develop.
Good. Very good. So it is just less than 5%. Okay. Dr. Shruti, we did the investigations, urine routine and culture were done. Your comments on the findings on urine routine?
So urine routine is showing hematuria as well as pyuria, sir.
So is this pyuria?
Yes, sir.
It would be labeled as pyuria, but it may not be reflective of
Not be
infection
reflective
yes, because when blood is coming, it is not always reflective of a infection. Okay.
Yes.
Yes. Yeah. So what would you do next in this patient?
So next, I would like to get a ultrasound abdomen, pelvis, and kidney, ureter, bladder as an extension of a physical examination to guide the further management. Sir.
Correct. Okay. So just give me the list of investigations that you would advise in the OPD to this patient.
So apart from the ultrasound, I would also do a chest X-ray and routine blood investigations, including a hemoglobin, total counts, the platelet counts, the renal function test, the liver function test, the calcium, and LDH.
Very good. Very good. So why do you need a LFT in this patient?
So we need to look at an LFT to rule out any metastasis to the liver, sir. We are doing a metastatic workup. So for that, we need to get an LFT, sir.
Okay, so
if the patient will
any other relevance that LFT may have in the management of bladder cancer patients?
So for BCG, if we are, that is much further in the after TUR BT, if it is, we are planning for an intravesical BCG, and we are giving, if the patient develops a systemic BCG symptoms, then that may be, we have to think about
agreed.
that.
Very good, very good. Okay, so any other specific relevance in invasive bladder tumors? So if you have to decide the diversion, which form of diversion the patient needs, LFT is a prerequisite for that. Why is that so?
Sir, we have to.
Dr.
We have to
Tushar?
assess the patient's albumin for planning any major abdominal resection. That becomes
specific to the urinary diversion, the choice of urinary diversion. Okay, no issues. Tushar?
Patient.
Yes, sir. Yes, sir. Sir,
Yes, yes.
We have to have the basic liver function test for the preparation for anesthesia also. First thing, if you are
what I am
to...
asking is specifically with respect to the choice of urinary diversion, which urinary diversion that we may be able to offer. For that, why is liver function important?
Yes, sir. Sir, as he is a young male, if you are planning for a continent external diversion, LFT should be normal.
Why?
The resection of the ileocecal junction in patients with deranged liver functions will further lead to a decompensation of liver function.
No, it will not lead to decompensation of liver function. What happens is, because the urine is coming in contact with the bowel, the urea and ammoniacal substrates get reabsorbed into the circulation, and therefore if the liver function is not adequate, there would be ammoniacal encephalopathy.
Yes.
Ammoniacal issues. Okay.
Okay.
That is why liver function has to be important and must be done. So ultrasound, chest X-ray was done, which was normal, and ultrasound was also done, which showed a 4 into 4 centimeter irregular mass at the base and right lateral wall, along with right hydronephrosis. Okay. So which investigation would you like to do next, Dr. Aditya?
I'd like to do a contrast enhanced CT scan urography of the patient.
Of whole body?
No, of the abdomen and the pelvis. And I would also like to do a CT chest for this patient.
Okay. Dr. Tushar, you would do the same thing?
Yes, sir. I would like to do a contrast enhanced test. Contrast. Yes.
Okay. So CT abdomen is the investigation of choice for these patients. Dr. Shruti,
Yes.
would you like to advise a PET scan?
No, sir, not at this stage.
Why? A PET
So we
CT
will
can give you all the information that a CT can give broadly, and it will also simultaneously assess the whole body.
So CCT would be better for a local staging, sir. For the T stage, we need to know the T stage, the end, that would be better delineated on a CCT. Also, we would be able to, since the patient has hydronephrosis, we need to see the drainage, for which we require CT urograms. So that's why that would be better, sir.
Yes.
And to rule
Okay.
out upper tract PCCs.
Okay. So for diagnosis and for staging purpose, PET scan is not a good modality, particularly for the T stage. It may be relevant only when there is an issue of diagnostic dilemma about the presence or absence of enlarged lymph nodes. Only then, subsequent to a CECT, we may advise a PET scan. Okay.
Yes.
So this was the CT which was done. I don't know whether you are able to see it. So what all actually you want to see in the CT, Dr. Aditya?
Sir, in the CT scan, we want to first look at the bladder, the local pathology, whether the tumor is grossly infiltrating into the perivesical space macroscopically.
So can you identify the? Can you give me a T stage for this kind of a tumor?
Yes, sir.
Are you able to see the enlarged image?
So yeah, yes, sir, I'm able to see.
Okay.
So this seems to be infiltrating into the surrounding areas.
Yes. So what do you call?
This seems like a T3
how do you
disease.
say that? How do you say that it is infiltrating?
Sir, we can see some fat that is
fat stranding or a perivesical streakiness.
Yes, sir.
The term is fat stranding or perivesical streakiness. Okay.
Yes.
And what else tell you that it may be an invasive tumor?
The dilatation of the upper tract is another
dilatation
marker
of the upper tract. You can see the contrast in the lower ureter, but on the right side there is no contrast and it is dilated in the ureter. Very nice. What else?
Sir, even on the posterior aspect, there seems to be some infiltration.
Yes, there is perivesical streakiness that we agreed. See, other thing is the loss of distensibility on this side compared to the rest
compared
of
to the opposite side.
Yes.
Yes, sir.
Okay, so this is what you actually you want to come out with, these points which indicate that it may be a what is the T stage?
T3, sir. T3.
So it is at least a T3, a clinical T3 stage.
At least yes, sir. Yes.
And the seminal vesicles are not involved. Okay.
Yes.
So simultaneously, we need to actually tell about the pelvic wall, the operator muscle and the levator muscles, which are there on the lateral aspect, whether they are invaded or not.
Yes.
And then we also need to tell about the lymph nodes till the level of bifurcation of the aorta, till the common iliac level. It is considered as the regional lymph nodes, and above that it is considered as the metastatic lymph node. Distant metastasis. Okay, so this is all what you have to tell.
Yes, sir. Yes.
And then the status about the proximal
the liver and the other
and the liver, ascites, etc. Okay.
Yes.
Yes.
So, Dr. Shruti, what is VIRATS?
So it is a scoring on which is based on the MPMRI. It is divided into 5 scores and predicts the probability of the bladder mass being muscle invasive. So it is used before a biopsy for a predictability to just assess the T stage.
So is it required in this patient?
No, sir. Because in mainly the VIRAT scoring is to differentiate between T2 and T3A, where it has microscopic involvement. But in this, the CT scan clearly is showing a T3B and beyond. So there might not be much role of doing a VIRAT scoring.
So I agree. but the prime focus is to actually differentiate T1 from T2. Because the treatment for T2 versus T3 remains grossly the same, whereas T1 versus T2 changes drastically. Okay.
Yes.
Yes. Yeah. So, another point important is that it is based on a MP-MRI system, same as the prostate. It is not simply asking for a MRI of the abdomen. It is actually MP-MRI on which a wide scoring can be given. So now what next? Dr. Tushar, we have the CT which shows a clinical T3N0 disease. So what would you do next? Dr. Tushar?
Sorry, sir. Actually, I got some interruption.
So what would be your next step? We have this CT of a patient which shows
Yes,
a
sir.
clinical T3 stage N0.
Yes, sir. Yes, sir.
What would you do next?
Sir,
would you like to do a repeat TURBT?
yes, sir.
Would you like to do a PCN for the right kidney?
No, yes, sir. I would like to do a cystoscopy first, and then I would like to assess the whether tumor is resectable, or and then I will plan accordingly, sir. If tumor is resectable, then
can we directly go ahead and do a radical cystectomy in this patient?
Sir, as this is T3 tumor, sir, I will counsel the patient, sir, first, patient and relatives. Because patient is young and if he's willing for early cystectomy, then that will be the also option for him, because it is a recurrence of tumor and it is T3 stage, high-grade tumor.
So the term early cystectomy is actually used for when you are dealing with a non-muscle invasive. When you are dealing with a muscle invasive tumor, you don't use the term early cystectomy.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
But radical cystectomy may be discussed with this patient, but as of now, from the exam point of view, it is always better that we have a documentation of muscle being invaded on a pathology report.
Yes.
So we will go ahead and do a TURBT in this patient as a first step.
Yes, sir.
And
yes, sir.
Why is estimation of GFR important in this patient? Dr. Tushar?
Sir, yes, sir.
Should we assess for the
Yes, yes, sir. For estimation of GFR is important to decide on the diversion, urinary diversion, sir. If it GFR is more than 60, we can plan for continent diversion also.
And split GFR, is it important in this patient? Would
sir,
you like to do a PCN in this patient before doing a TURBT?
Sir, actually PCN is not required actually, because creatinine is normal. So we can plan for a radical surgery, sir, first, and then we can plan for diversion. Yes.
So diversion is not needed at this moment because the patient has a normal KFTs. But it is important still, because we need to decide about what we have to do about the right kidney, because we have seen in the CT urography there was no contrast excretion even in the delayed pulse.
Yes.
So renal scan was also done, but it showed a 37% function on the right side, and eGFR was calculated based on the MDRD formula, and it was 70 ml per minute. Okay. So the treatment was advised in terms of we have decided that we will go ahead with the TURBT first, and PCN is not needed. So how will you go ahead doing a TURBT? Dr. Shruti, what are the important points that you will specifically like to highlight during TURBT?
So first, starting from the anesthesia point of view, I would like to ask for a anesthesia with an obturator block or a general anesthesia with muscle relaxant, since I'll be resecting on the tumor is on the lateral wall. Then I'll start with a bimanual examination to assess the fixity of the bladder mass to the pelvic wall, and to have a preoperative assessment of the size of the tumor, and I will do the same after resection, as well as a general palpation of the abdomen to assess post resection if there is any perforation, if we can feel any distension.
Would you take random biopsies in this patient?
So I will take a biopsy from the prostate, sir.
Why?
Bladder neck to assess whether there is any involvement of the bladder neck or prostate, because that would because assuming that this patient will later require a radical cystectomy, that would help to decide the choice of the diversion or conduit or neobladder, sir.
So supposingly your biopsy from prostatic urethra comes as positive, would you not like to do a neobladder?
So we would take a frozen section from the urethral cut margin intraoperatively.
Okay,
but
very good. So you do not deny orthotopic neobladder just based on the prostatic urethral biopsy. But 5 minutes. Yeah, I'll just rapidly go through, sir, whatever we can cover. So if the prostatic urethra biopsy comes as positive, we need not deny the neobladder, but in those cases we must take a frozen section from the distal margin. So this was the TURBT which was done, and you can see the trigone was involved completely. The right ureteric orifice was not seen, and it was a large mass. And the aggressiveness of the tumor can be assessed based on simply the visual impression of the surgeon. And I would just go through them: the width and extent of the base of the tumor, whether the base itself seems involved, that is the detrusor muscle, the size of the tumor, and whether the papillae are solid or fused, and whether there is necrosis, superficial calcifications, and the vascularity. So all these things do tell the surgeon directly whether one is dealing with the aggressive tumor or not. Okay, so the biopsy comes out to be the invasive disease T2, and it is high grade with focal squamous differentiation, and there was no lymphovascular invasion. So what would be your choice of treatment in this patient, Dr. Tushar?
Sir, I would like to prefer for neoadjuvant chemotherapy because, sir, as we are planning for we can plan radical resection after neoadjuvant therapy. So
the advantage of giving neoadjuvant chemotherapy in TCC is that it gives about 5 to 8% of absolute survival benefit. And
yes,
it can be, and it should be considered and must be discussed with the patient, particularly those who have a normal or at least a GFR of more than 60 ml.
Yes, sir. Yes.
Dr. Aditya, is this patient a candidate for bladder preservation? If he says, no, I don't want a radical cystectomy, can you offer him a bladder preservation?
Sir, in view of the unresectable mass that he had, plus the fact that he has a right side hydronephrosis, he would not be an ideal candidate for bladder preservation.
Good. So presence of upstream hydronephrosis,
multiplicity large size of mass. Yes, sir.
Yes, and large size of mass, which is not resectable mostly. So then bladder preservation is not a good option for such patients.
Yes, sir.
Okay. So would you like to offer him sexual preserving cystectomy, Dr. Shruti?
Means
you would
so
like
that
to
depends
preserve
on the operative sexual function, sir, because that is the
no,
highest.
He is young patient, sexually he is active, and he has a good erectile function.
Yes, sir. Then we will offer him sexual preservation radical cystectomy, sir.
So a contraindication for a sexual preserving cystectomy is the presence of tumor in the bladder neck or the prostatic urethra. In this patient, you may not have been able to see the complete TURBT findings. It was involving the bladder neck, so it was not offered, and it is not a good choice. Okay. And what type of diversion should we offer to this patient, urinary diversion, Dr. Aditya?
Sir, I will discuss with the patient about continent versus a neobladder versus a conduit. I will. The patient is eligible for both based on the findings that are available, and depending on the choice of the patient, because he's a young male, he would be fit to undergo do a self calibration if required. And so, depending on the choices of the patient, I would counsel the patient and proceed as per his preferences. Sir.
Dr. Tushar, where would you mark the conduit?
Sir, we have to mark conduit between the lateral 2/3 and middle 1/3 from umbilicus to enter superior iliac spine on the rectus abdominis muscles.
So yes, that is the approximate side, but one should carefully see where the crease, the belt line is. We should try and avoid the belt line. And in particularly centrally obese patient, we actually need to avoid the underside of that abdominal bulge. The side should always be on the area which is visible to the patient. Okay.
Yes, sir. Yes, sir.
So this was the cystectomy was done, and just the final histopathology showed a T3A disease, and there were multiple lymph nodes positive. So it was an N2 disease, and there was lymphovascular invasion. Okay. So what next would you do, Dr. Shruti?
So we would plan for adjuvant chemotherapy, sir, after this.
So if the patient has already received, let's say the patient had already received neoadjuvant, and this is the final histopathology, would you still give adjuvant? Same drugs?
Yes, sir. We after giving 3 cycles of neoadjuvant therapy, we plan radical cystectomy followed by another 4 cycles of adjuvant chemotherapy, sir.
So a patient who has received neoadjuvant, we actually need to see how much the disease has reduced. So assuming that his disease had not reduced with neoadjuvant, it is better to choose other drugs than what was chosen for the neoadjuvant therapy. So what is the most common drugs which are used for adjuvant or neoadjuvant therapy?
Cisplatin and combination of cisplatin and gemcitabine, sir.
Okay. And what is the alternative?
Carboplatin can be given, sir, if GFR is less than 60.
And
any
other regimens?
So there is dose dense MVAC regimen.
MVAC regimen.
Yes. So MVAC regimen is the other which can be used. Okay. Is there a role for radiotherapy in this patient, Dr. Aditya? Role for radiotherapy?
I am not aware, sir.
Okay. Dr. Tushar?
Yes, sir. According to NCCN guidelines, we can give adjuvant radiotherapy to the local areas. Because
no, see, actually radiotherapy can be given both pre-operatively also and post-operatively, but the survival benefit has not been shown to be there with radiotherapy. So it is most of the times not used. It is used only in cases where the surgeon feels that there is a residual disease left. That is R0 resection has not been achieved. Okay.
Yes.
So Dr. Chawla, I think we would
no, Rishi, I think you have comprehensively covered the case.
In the interest of time. So I'll just give the carry-on messages. The radical cystectomy is the choice of treatment for T2 and above disease, and also some patients who have high risk NMIBC. And we should not delay cystectomy. It should be offered to and must be discussed with the patient as early as possible wherever we have confirmation of a muscle invasive disease. And pre-op radiotherapy is definitely not recommended these days. Post-op radiotherapy may be considered in a few patients depending upon whether the surgeon feels that the R0 resection has been achieved or not. And lymph node dissection is an integral part, and the extent is dependent upon the surgeon, but at least standard lymphadenectomy must be done with all kinds of radical cystectomy. And the urethra can be preserved if the frozen section from the urethral margin is negative.
Yes.
And regarding the technique, there is no advantage of one over the other, except that there is a relatively less blood loss in minimally invasive techniques compared to the open technique, but over the long term, there are no reported benefits of one over the other. And I think we would leave at that. Okay. Thank you, sir. Thank you from my side. Any questions?
Okay.
I will be happy.
Yeah, we'll ask them to put in the chat box. You can have a look at the chat box. Navneet, Dr. Shrenik Shah will take up the next case, and please inform who are the agents. Dr. Shanik, over to you.
Yeah, thank you.
Thank you.
Can I have my first slide, please? And who are the students? Can I know the names of them?
We have Dr. Sajad, Dr. Suraj, and Dr. Harmanmeet Singh.
Okay, perfect. Can I have my first slide, please?
Dr. Sanket Kankaria, last.
We're not seeing the slides.
Yeah. Just that is what I am asking. Let me see. Yeah. Okay. Yeah, can you probably see, have I shared it? Wait, let me share this first. Okay, can you see the slide, please?
Yeah, we can see now. Okay. Please go ahead.
Perfect. Okay, he's a 55-year-old gentleman and has a right flank pain. Can you please tell me what are the options you will think at this level?
So it could be a right renal calculus.
Stone disease.
Okay.
Do I want to know more about me? But given this history, right renal calculus.
Okay. I'll give you the next one. He was asymptomatic before a month. Then he developed a right flank pain, which was mild dilating, and no other history of like hematuria, pyuria, avoiding difficulties, frequency, urgency, or the back pain. So still you have stone disease, or would you think something else also? Any other idea?
Sir, with this age group, my first differential diagnosis would be stone disease, and I would also consider other things like with the dull aching pain. I would also consider malignancy as a second differential diagnosis, most probably RCC or TCC of the renal pelvis, in that order.
So in RCC, when does one would have a pain?
Sir, if the tumor has a intratumoral bleed or there is an infarction in the tumor, then the patient might present with flank pain.
So that is a second common. Anybody else? Would you like to put any other differentials than these two diagnoses what have been kept?
So right PGO we can think, though age is 55, but still right PGO I'll still take into consideration.
Yes, correct. Patient can present at any age, correct. That could be the third differential. Anybody else? Would you like to put anything else?
Right retrocable ureter.
Okay, then. All right. So, common you would put stone, UJ, and the malignancy. That is what we understand, right? Okay, let's go to the past history. The gentleman had no positive history of any hypertension, diabetes, tuberculosis, family history, nothing specific. Personal habit is definitely one thing. Smoking, which is significant. Do you think is it a significant, or do you think it does not matter much? How do you decide that smoking is important or significant?
The duration and the number of BDs, the number of pack years.
Yeah. So what duration do you consider it is significant? What duration?
I think more than 10 years.
More than 10 years.
Correct. Okay. All right. So then, what would you like to do? The general examinations? The general examinations are normal. What is your area of interest? What next would you like to do?
I would like to get an ultrasound.
No, wait. Clinical. I'm talking about clinical examination. Would you do the per abdominal examination or not? Or
yes,
I think in the era of ultrasound and CT scan, we may not need really that. What do you think?
Per abdominal examination is to be done, sir.
Yes, very good. Okay, so there is a fullness in the right renal angle, okay? And when you are doing palpation, you are absolutely able to see that there is a mass which you are able to palpate, and that is in the right lumbar region, and it is a little firm to hard in consistency. Tell me now. I think about your the same the differentials at the end of the examinations, or you believe you would like to change this?
Would like to put malignancy as the first order diagnosis, as the first DD.
Okay, so what will you do at this level? Tell me.
Confirm the differential diagnosis by going with ultrasound as an extension of the general examination.
Okay, so we'll go through the different scenarios. You got an ultrasound done, and there is a right-sided gross hydronephrotic kidney, and there is a lot of internal echoes inside. What will you do now? What is your diagnosis, and what will you do now?
It could be a stone disease with a pelvic stone obstructing, or a PUGO.
Correct. No, but correct. That is right. So now what will you do? That is the question.
Like to go ahead with a CECT of the abdomen pelvis with
yeah, so there you made sure there is no stone disease. It is PUGO with a lot of internal echoes.
Right. So before that, I would like to get CBCRFT done as well, sir, and you didn't read culture.
Very true. Very, very, very important. Yeah, the counts are 26,000. Very true. What next? And creatinine is 2.6. Now, what is the next plan of management?
The creatinine is 2.6 and is infected hydronephrosis. Then I will go for PCN if it's a hydronephrotic kidney.
What size PCN? How would you put that?
Ultrasound guided, I will put the patient into one position after giving antibiotics to the patient.
Okay.
12 or 14 French PCN.
Yeah, how do you, can you just tell me the steps? How do you put that?
Okay.
You
First
say
patient
position.
We have to make sure the patient has got IV
right?
antibiotics. Number two, we have to make sure the patient has got IV line with IV fluids running. And after taking proper consent, after taking the coagulant or PTI measures beforehand, the first step is prone position, and we'll put a pillow beneath the abdomen so that we can have a good area. And after that, we'll put a probe there, and we'll take then we'll give a local anesthesia to we'll mark the area where we want to go for PC.
Correct. And, where do you normally go? Where do you normally go? How do you decide where do you end up?
Beneath the 12th rib and lateral to the rectus spinae muscle.
Correct. Very true. And then would you like to confirm it? Would you do something, or you will straightforward?
Yes. First, after giving local anesthesia, I'll give I'll put a needle and we'll see the outflow. How is it?
Correct.
The color, the consistency, and
it is pus. Yeah, it is pus is coming out. Yes. Okay. Then
the pressure with which the pus is coming out, and after that I will gradually dilate it. After putting guide wire, I will gradually dilate the tract.
Which guide wire do you put? What size and what type of? Are there any specific things important? Do you generally put J tip or straight tip? What do you prefer?
The floppy and
floppy tip, sir. Floppy tip.
Floppy.
Correct.
And after putting the guide wire, we'll take out the needle and then we'll gradually dilate the tract using the technique. And over the dilated tract, we'll put the PCN.
Correct.
Then we will secure the PCN tube with the suture and we'll connect it with the bag. And more importantly, we will take culture out of the pus as well from the tube.
Okay.
Yes,
okay. All right.
We'll fix it.
So,
yes, sir. And
so just understand, this is a purpose. You must know, if don't make up your mind that there is only one thing is possible, even though at times hard mass can have a differential thing. And that is what you should really try to understand. All right. Okay, let's come back to our case. But always remember, there could be many more differentials and somebody can really change the finding, and then you may not really, you may be mentally prepared with one type of a case, but things can be very different. All right. Similarly, here the question could be, if there is a some stone is there in the ureter, then you may have to probably handle it again with that. Oh, obviously, fine. We come back to our own original case, and that is what our purpose. Let's go to the next one. Yeah, on percussion, this is done. The dull note is present over the mass. And let's go to the next. Okay. Now what would you do with your original hard mass? What kind of test you would like to have? When you said the blood test, you would always like to get, right? Hello?
Sir, we could not hear you, sir.
Question. We didn't get the question.
You are not audible properly. Sir, you are not audible.
Shanik, I think maybe connectivity issue. We'll just, I'll call him and find out.
Hello, am I audible now?
Yes, sir.
Yes, sir.
Okay. Actually, sorry, I was traveling. I went for inspection. I was on the way. I didn't want to miss this, so I just. But now I think if I'm audible, then things should be good. Am I audible, right?
Yes, sir.
Okay, perfect. You can have video. So now I'm back to this. All right, let's go to the. So we were at the level of blood investigation, right?
Sir, the slides are not visible.
Okay, wait a minute. I'll do that. Wait a minute. I was sharing the screen. Okay, this was what I was sharing. Yeah. Is it okay? Can you see now?
Yes, sir.
Yeah.
Okay, perfect.
Yes, sir.
So the blood report, if you will see, they are, I think, apparently the kidney functions and everything is okay. Anything specific you need apart from this? What next? Tell me. What next would you like to have? Next, what is the choice of investigations? Ultrasound or CT scan? What would you like to have? Why are we thinking about that? We are talking about this case now. What next?
Ultrasound abdominal pelvis.
Ultrasound.
Okay. All right. So I think urine also is normal. Yeah, this is ultrasound. Anybody can read the image? Anything positive? Anybody can tell me about that?
Sir, right kidney seems to be enlarged with a high. I mean, with a central mass towards the lower.
Okay, fine. Yes, there was yes, correct. There was a mass. Now we are just going through the report because the image was okay. I hope you are. How many of you are doing ultrasound on your own? If you are doing ultrasound on your own, I am sure you should be able to pick it up also very well. All right. So there is a mass. What next? Tell me. What next would you like to have?
Next would be a multi-phase CT, sir.
Correct. Okay. Tell me. I wish all of you to read CT on your own. Never read the report. That's one of the very important things. So tell me, what positive thing are you seeing in the images? Can you tell me that?
Right kidney seems to be, this seems to be a plain image, or like a plain CT. The right kidney seems to be enlarged in size. There seems to be a mass arising from the upper pole, occupying the mid pole region also. I would need contrast images for further commenting on that. The left kidney seems to be normal in these sections.
Agreed. I agree. We are going to have that. Looking for the left kidney, anybody can tell me that? Do you say find between the left and right kidney, look at the site of aorta, IVC, do you think everything is normal?
There appears to be a left paraortic nodal mass.
Yes.
But it's difficult to comment upon this. So we need this contrast films for that.
Okay, so next we are going to the next image. Anything now?
The right kidney appears to be replaced almost by a mass lesion. The left kidney appears normal.
Okay, I'll show you one more image. Anything now?
Looks like IVC thrombus.
IVC seems enlarged, sir, widened, and the renal vein also looks enlarged in size. Probably there is a tumor thrombus.
We still have the non-contrast images, sir, but it's
better to comment with a contrast.
Better to comment with contrast.
Correct. So if we are going through the left kidney, see earlier images, if you see, they were probably the earlier images shows. This are this is probably the contrast image. You can see the left kidney very well functioning. Yeah. And the right kidney more or less it is replaced. But if you will see that there is a mass in the renal vein also. All right.
Yes.
I think IVC is okay. You will like to see the next image. Yeah, look at the now report. It is 6 by 6 centimeter well-lobulated mass which is arising from the mid-pole, and the lesion is extending into the pelvic axial system and causing the distortion, and that is a renal vein is completely but fortunately the thrombus is going right up to IVC, not involving the IVC, and multiple nodes. What I was showing you earlier, there were multiple pre, para, and all the lymph nodes were there. That was the most important thing.
Right.
Okay, now let's go to what will you do? Tell me, any one of you. What is the stage and what will be your plan of management?
T3AN1.
T3AN1.
T2A.
I would like to see the metastatic workup as well, sir, like the chest X-ray and the
very important. Yes, CT. No, my chest. I would say already you are getting a good CT. CT thorax is normal. There is no metastasis. LFT is normal. There is nothing else. Nowhere else it is there. Yeah.
Yes, sir. So I would like to stage the T2B, N1, and M0. So the stage would be stage 3, sir. Locally advanced RCC.
Correct. What will you do now?
Shouldn't it be T3A?
Yes, sorry, T3B, sir.
T3AN1M0, sir.
T3B, N1, M0.
Okay, fair enough. What will you do? What next? Tell me.
T3A.
Okay.
Sir, I would go ahead with resection, sir. The radical nephrectomy, the lymphadenectomy.
Yes, with lymphadenectomy. How will you do that? Tell me.
Sir, based on whatever is available, like if lap or open, I would try to choose.
You only have to say. We don't have to do the ideal thing.
I would choose a open radical nephrectomy, sir. I mean nephrectomy with the removal of the right kidney along with the Gerota's fascia.
Like to have a midline incision.
Okay. Tell me this principally. What position, what incision, and how we do.
So it would be a supine position.
Okay.
Preferably, we can have a midline incision or we can have a chevron incision. Both of them are good. The exposure needs to be good. We have disease on bilateral side of the retroperitoneum.
Looking at these imaging characteristics, my main aim would be for a better exposure of the hilum and also the IVC. So considering this, I would like to go with the trans-abdominal route, a trans-peritoneal route with midline or chevron incision.
Yeah, you are mobilized on the right side. What you will be really concerned? Tell us that principle, sir. You have done colon mobilization. What next?
Yes,
Then we go to the intra-aortocaval groove and take hold of the right renal artery at the level of the renal hilum, so that we might take good control of the hilum itself.
Before that, on the hilum and the renal vein, would you come across any other specific?
Cauterization.
We have to cauterize the duodenum first, sir.
Yeah. Don't forget, because it is right side. Okay, that's something. This is the left side and right side that we need to be very clear about that. Okay, fair enough. You have taken care of duodenum, because this is very, very important organ that we need to be very careful. Okay, you have taken care of duodenum. Now you are able to see multiple nodes, but you are very well able to see the thrombus, and there is a IVC is separate. IVC is not involved. Now, how would you handle this?
We can.
If you can put a clamp below the thrombus and taking enough margins, then you should be able to do the first take care, obviously dissect out the artery also. And you have to dissect the upper pole, lower pole, lateral, everything, make the kidney free all around as you're doing open surgery. Then go posterior, have a better control of artery first. First you have a better control of artery, then you put a clamp below the thrombus, and then you take care of the artery and completely en masse to remove the specimen. And whatever possible lymph nodes, you are able to remove it. That's fair enough. All right. This is little, I would say, what the purpose of showing this case was that if there are lymph nodes, first of all, identify the lymph nodes. And if possible, if whatever safely you can dissect out. There may not be a purpose of curatively that you have to go and remove each and every lymph node. All right. And that was, yes. We did any other method. Yeah. Some you would see it open. Anybody would do any other method? Anybody has seen the other or the minimal invasive probably in today's era? If you can do that, laparoscopic or robotic, believe me, we did this laparoscopically, because once you are able to put below the thrombus, and if you are getting the same what you are doing in open, if you can probably put a clamp over there, and if you can put a clip, we put a clip right away, Hemolock clip over there once the artery was under control, and then you can do it. But fine, fair enough. It is not important whether you're doing lap, robotic, or open. What you principally have said that you do the definitive surgery is more important. Okay. And this was a histopatho. This was clear cell carcinoma only. This was grade 2. The necrosis was 10%, margins were negative. And the tumor did extended in the renal vein, fat sinus, and this was a pathological stage. Anything extra that you will do, or are you happy with this? What is a 5-year survival, and what do you think how the patient would do in the long run?
Stage 3 survival is around.
Yes.
5-year survival is around 40 to 50%, sir.
No, anybody? It is still better, believe me. If it goes into IVC thrombus, and if it is involved, it is still better. Remember that. Here you have done a curative or complete treatment for them. So maybe I think you would consider that 40 to 60% even. This is pretty good. This is, if it has gone, the thrombus has gone above in the IVC or would have been gone anywhere else, would have really taken care. And it is still grade 2. How would you keep this patient in the follow-up? What would be the follow-up of this patient? You have done a curative excellent surgery. What next would be?
Sir, on follow-up, I would like to image him with a CT First
How
every
frequently?
3 months.
Yeah.
Every 3 monthly, sir, for the first 1 year, and then
Annually
6 monthly for the next 2 years, sir, and annually for the next in the follow-up period, sir. Mainly because the lymph nodes were enlarged, and with the histopathology NX, so most of the lymph nodes were not removed. So he might be having a local recurrence. So that is what I would be monitoring him for, sir. And once the nodes are positive, the chance of him having a metastasis is higher. So I would also get a CT thorax in the follow-up examination.
Correct. And if it is positive, would you like to do anything else?
Sir, if there is a local recurrence, there is some improvement, there is some survival benefit with going ahead with and resection of the local recurrence as well.
Correct.
And
so I think you are any other immunotherapy would you like to give and any role especially?
Sir, adjuvant roles as of now, only sunitinib with the extract trial has shown some benefits. Apart from that, all other trials have not yet shown the benefit, but multiple drugs have been tried upon this stage.
Okay, perfect. So I think what are the most important thing that you should really think about is any renal, the upper tract mass or whatever renal fullness or renal mass you are seeing, just be prepared for many differentials starting from, and even though you believe me, I would always recommend that don't see the case. Let me put it that way. If we know the case, then our mindset is very different. Somebody can absolutely change the finding. Could be starting from pyonephrosis, PUJ, upper ureteric stone, or even the renal malignancy, or even upper tract TCC. Could be have been even fungal ball in the pelvis. So could have been many differential diagnoses. So just any mass when it is palpable, try to do a good clinical examination has still got a very important role. If we summarize this, be prepared depending on what finding after a history examination. The real role of what you asked was the total count when we were telling the pyonephrosis has very important role, creatinine, how to do the diversion if those kind of different scenarios. And then if we come back, if it is a purely malignancy, if RCC is different, if it would have been upper tract, tell me if it would have been a real mass of maybe 2.2 centimeter in the renal pelvis, what you would have done for the same gentleman? And has got a mass palpable, that's all, nothing beyond that. Mass is only in the renal pelvis, about 2.2 centimeter. How would you handle that mass? And it is proven TCC, you have taken a probably biopsy, so there are no other doubts. Yeah.
So more than 2 centimeter, it would fall in the high risk stratification group. I would like to proceed with a radical nephroureterectomy with a standard lymph node dissection.
Again, apart from open, anybody else can say how would you do this nephroureterectomy?
We give two incisions.
Doing it open.
Correct.
It can be done minimally invasive.
Yeah. See, here probably the real role of minimal will come because you can do the nephrectomy very well, and probably putting a one port down, you can do a good bladder cuff of it. So at least in today's time, if someone asks whether you have seen or not, or whether you are doing it, but theoretically you should definitely be able to answer. Okay, it can be very well done, I think, in a single setup. Okay, so that would even cover your upper tract TCC also. And that's all. I think if any questions you have got, let me know. What we are looking forward is like any renal mass and with multiple differentials. Anybody, let me put one more condition. 2.5 centimeter, 7 centimeter below PUJ stone. What will you do? Investigate. Treatment. We consider it's a well-functioning kidney. Everything is good. What will you do? One of you should answer.
Can you repeat the question?
2.5 centimeter long stone in the upper ureter. On the right side only, we are talking 7 centimeter below PUJ.
The laparoscopic ureterolethotomy.
Lap ureterolethotomy.
Absolutely perfect. That's the choice. Remember that. You or one may do, I think, open if suppose not available, but don't talk about RIRS, don't talk about PCNL, just be very clear. So Real choice is this. Excellent. I am happy. Now, Charles, go ahead if you have any other question.
we
I was
can
trying to cover the renal mass with multiple differential diagnosis. Yeah, tell me if anyone has any questions.
Shrenik, what we'll do
please.
is tell these residents to post question. Please stay
Okay,
online.
perfect.
And
Yeah,
open the
I
chat
might
box
have
at
exceeded the time. Okay. No.
Okay.
I'll stop. Absolutely, I'll conclude.
I
Thank you very
appreciate
much. All of
invite
you have done a good job, and I believe good luck to all of you.
Thank you.
And
Thank you,
do
sir.
your best in the exams. Yeah.
Shrenik, thanks very much. In spite of traveling, you came online and you took your.
I'm sorry. Yeah, I was traveling earlier in the car, and I was not. My video was also not on. I would have not liked, but I didn't want to miss the session. Yeah.
No. We appreciate your passion for teaching, and you came online in spite of your busy schedule. May I invite Dr. Rajiv TP for his. Now we are left with two important conditions. I think these conditions, they can come as a theory, they can come as a ward round, as a full case. But the two expert faculty who are covering these topics are Dr. Rajiv TP and Dr. Venkatesh Krishnamurthy. They will, in a capsule of around 15 minutes, they will update you about the what you can say and the full of this particular conditions. May I first invite Dr. Rajiv TP to start his lecture. Dr. Rajiv TP, over to you.
Can you hear me?
Yes, sir. We can hear you, sir. Please go ahead.
Cancers of the penis are uncommon tumors in the developed countries, but it constitutes a very substantial health concern in many African, American, and Asian countries. Accounts for around 0.4% to 6% of all malignant neoplasms in the Western world. Diseases of older men, and it can abruptly increase in incidence in the 6th decade of life. And majority of the lesions are squamous cell carcinoma. These are the various pre-malignant conditions, just to have an overview, like cutaneous horn, bovinoid papillosis, condyloma acuminata, balanized gerotica, Buschke-Lowenstein tumor. Now, what is carcinoma in situ? It's a penile intraepithelial neoplasia. It's also called the erythroplasia of Poiret. It involves usually the glans penis and prepuce, and it appears as a red velvety, well-marginated lesion of the glans penis, and or less frequently the prepuce of the uncircumcised man. It can ulcerate, and it is maybe associated with discharge and pain. Bovinoid disease involves the penile shaft or the remainder of the genitalia, or it can involve even the perineal region, and it is characterized by sharply defined plaques of scaly erythema. It can be crusted or ulcerated variants can also occur, and if not treated, then it can progress into invasive carcinoma in about 5% of the patients. Treatment of these lesions, when these are located on the foreskin, circumcision or excision with a 5 mm margin is adequate for local control. Some people have gone for glans reforeskin for penile squamous carcinoma of the glans penis, application of 5-fluorouracil, ablations with NDR laser or KTP laser or carbon dioxide lasers have been tried. Now, invasive carcinoma, the etiology being lack of neonatal circumcision, poor hygiene, presence of long-standing phimosis, then HPV infection, multiple sexual partners, exposure to tobacco products, and penile trauma has also been implicated. And the locations are majority is found on glans, followed by prepuce, corona, and in the shaft in less than 2% cases. Clinically, it presents various presentation ranges from a very subtle induration to a small papule, pustule, warty growth, or sometimes there can be a very luxuriant exophytic lesion. It appears as a shallow erosion or as a deeply excavated ulcer with elevated and rolled out edges. Rarely a mass, ulceration, suppuration, or even hemorrhage from the inguinal area caused by nodal metastasis from a lesion concealed within a phimotic foreskin. Urinary retention or urethral fistula from local corporal involvement can also occur, but it is a very, very rare presentation. These patients in advanced stages have got a lot of constitutional symptoms like weakness, weight loss, fatigue, and on occasion, there can be significant blood loss from the penile skin, the nodal lesion, or both can be there. Examination involves the assessment of the patient totally, local examination for the size, location, whether the growth is fixed, and involvement of the corporal bodies. Inspection of the base of the penis and scrotum necessary to rule out extension into these areas. Rectal and bimanual examination for perineal body involvement and presence of a pelvic mass, and bilateral palpation of the inguinal region for adenopathy is extremely important. Laboratory studies to exclude anemia, leukocytosis, hypoalbuminemia, where instances there can be azotemia, and hypercalcemia should be done. The confirmation of the diagnosis is biopsy, and this should assess the depth of the invasion of the lesion, whether there is any vascular invasion, especially the lymphovascular invasion, and also the histologic grade of the lesion by microscopic examination of the biopsy specimen. Biopsy in a totalating dorsal slit is frequently necessary in order to gain adequate exposure of the lesion in some cases. Biopsy with fluorescent section done for confirmation, followed by definitive resection or ablation. Characteristic histological features in squamous cell carcinoma of the penis include keratinization and the typical epithelial fold formation, and there can be various degrees of mitotic activity. What are the imaging modalities which can be done? One is the penile ultrasound. In those cases, the lesion will be invariably hypoechoic, but sometimes it underestimates the thickness of the tumor. Cannot delineate invasion into the subepithelial connective tissue of the glans penis from corpus spongium involved, and that is, there is some difficulty, that is glandular stage T1 versus glandular stage T2. But tunica albuginea can be easily identified. And it has been found that ultrasound, penile ultrasound has got 100% sensitivity for detection of the involvement of the corpus cavernosum. Nowadays, penile MRI run for lesions which have been thought to invite the corpus cavernosum. One advocate contrast enhanced MRI augmented with artificial erection. This provides unique information, especially when you have some doubts in the physical examination. It may be, the physical examination may be equivocal, and when you contemplate organ sparing techniques. So these are the various showing a mass in the penile with invasion of the deep tissue. So DW MRI is widely used for detection, characterization, and evaluation, and evaluation of treatment response in patients with cancer in all cancers. Similarly, it can be done in penile cancer as well. Magliningan tissues have higher signal density on DWI and lower ADC values. Sorry. Now coming to the inguinal and pelvic node, pelvic region, node negative cases, CT have a role in examination of the inguinal region, especially in obese patients and in those who had a prior inguinal surgery, in whom the physical examination may be unreliable. Furomoxtan 10 particles administered at a dose of 2.6 milligram of iron per kilogram body weight intravenously, combined with MRI, were found to be capable of imaging even microscopic metastasis to the tune of 0.2 to 2 mm in size. Squamous carcinoma take up the radiopharmaceutical FDG and are amenable to detection using combination positron emission tomography and CT. In those with node positivity, distant metastases occur late in the course of the disease, usually in patients who have significant inguinal and pelvic adenopathy. Most common sites of distant metastasis include lung, bone, and liver. In these cases, chest, abdominal, and pelvic CT may be required. In some instances, radionuclide bone scintigraphy may be indicated to stage the extent of the disease in those patients, especially who have widespread metastasis. Now coming to the lymphotropic nanoparticle enhanced MRI, which has been widely used nowadays because these have got 100% sensitivity and 97% specificity, and the positive predictive value is to the tune of 81% for the detection of micrometastasis. Dynamic sentinel node biopsy has been done nowadays. It has got a high sensitivity as well as a false negative rate to the tune of 20 to 30%. Abdominopelvic imaging is done in those with clinically involved inguinal nodes to assess the presence of pelvic as well as retroperitoneal node involvement. This is a schematic representation for the various stages of the disease. And now today I've been assigned with the T2 lesion. T2 is broadly classified into T2A and T2B. T2A is basically involvement of the corpus spongiosum, and T2B is involvement of the corpus cavernosum with or without involvement of the urethra. This is basically important because T2B, that is involvement of the corpora cavernosa, have a worse prognosis compared to involvement of the corpus spongiosum. Next, along with this, the grade is grade 3. Grade 3 means poorly differentiated cases with lymphovascular invasion. So in case of T2 tumors involving the corpora cavernosa or corpus spongium without urethral involvement, with G3 lesion that is poorly differentiated with lymphovascular invasion. So lymph node involvement in T2 G3 lesions have been found more than 80%, up to the tune of 81%. And clinically 90 nodes are found to harbor metastatic disease in about 11 to 62% of the cases. So early local and regional disease should be treated to obtain a surgical cure. Advanced regional disease portends a poor prognosis. Inguinal node metastasis is the most important prognostic factor in case of carcinoma penis, and MRI and ultrasonogram used adjunctively to determine depth of invasion in these situations. Treatment, as you know, primary is the first priority in the treatment, and the modality depends upon the depth of the lesion and the extent of the lesion. For example, usually it is the partial or total penectomy that has been advocated, and now the resection margin is reduced to 5 mm. Earlier days, it has been said that there should be a resection margin of to the tune of 2 cm. Now it has been found that only 5 mm resection margin is required, and this has been the standard of care for the primary disease. Radiation followed by surgery has been advocated because carcinoma penis is a radiosensitive tumor, but it is a less common approach compared to surgery. And this has been done as a main treatment protocol in those patients who are found to be unfit for surgery. Now, decision for partial versus total penectomy, this is basically based on 4 factors, that is the volume of the disease, what is the grade of the tumor, the ability to obtain a clear margin, as well as the body habitus. Because in grossly obese patients, so even though the growth may be limited, we may have to advocate total penectomy because of the difficulty in obtaining a sufficient stump of the residual penis. Now, it has been found that increased risk of local recurrence occur when the margin of resection is less than 1 mm. Second factor is when there is cavernosal involvement, there is high risk of local recurrence. And third factor is lymphovascular invasion. So these are the 3 situations where there can be local recurrence following the primary surgical modality. Clinically, 90 nodes in the initially when it is presented can harbor metastatic disease in 11 to 62%. Radical inguinal lymph node dissection is the treatment which is advocated for palpable or resectable nodal disease. But if the patients are having bulky or initially unresectable nodal disease, one have to do a neoadjuvant chemotherapy to downstage the disease and make the growth a resectable one. Now, the modalities, one is partial penectomy. Just in briefly what you do, it is the surgical standard of care for invasive tumors of the middle to distal penis. A circumferential incision is made along the penile shaft, skin 1.5 to 2 centimeters proximal to the lesion. Dissection carried down from the skin to the level of the buccal fascia. Superficial and deep dorsal veins are ligated and divided. Corpora cavernosa is then divided, leaving the corpora spongiosum intact. Urethra dissected from the corpus spongiosum distally for a distance of approximately 1 centimeter and transected. Urethra then spatulated on its dorsal surface for reconstruction of the neourethra and for the prevention of stenosis of the neourethra. Ends of both corpora are closed transversely with interrupted absorbable strictures that incorporate the septum. Penile skin is then closed on the ventral surface in the midline with interrupted sutures, absorbable sutures. Then the after all spatulated urethra is then approximated to the penile skin in order to create an oblique meatus with its open side at the 12 o'clock position. This is just a operative picture. Now, total penectomy, patient should be in the exaggerated dorsolarythectomy position. Elliptical incision is made around the penis and dissection through the subcutaneous tissue dorsally with electrocautery. Then you go for the division of the suspensory ligament to the penis. Ligation of the superficial dorsal vasculature of the penis should be done. Then dissection of the urethra, and you should isolate it from the corporal bodies, leaving sufficient length to reach the perineum. Then urethra is divided and dissection of the urethra of the corporal bodies up to the pubic ramus. Now 1 to 2 centimeter elliptical incision is then made in the perineum, and this is carried through the dermis and subcutaneous tissue, and then the urethra is brought through the perineal opening. As I said in the earlier situation, your urethra is spatulated at the 12 o'clock position, then it is approximated. Now this is a picture of the total penectomy. Now coming to inguinal lymph node dissection, where it is advocated, usually palpable lymph nodopathy, you should always think about inguinal lymph node dissection. It should be evaluated promptly because it is highly suggestive of metastatic involvement. Number of palpable nodes, their character, including whether they are fixed or mobile, should be noted down. Clinically positive groin on surveillance should be subjected to unilateral radical inguinal lymphadenectomy. Opposite side, if it is clinically negative, one should subject to either a modified or superficial groin node dissection or a dynamic sentinel node biopsy. Radical inguinal lymphadenectomy is the procedure of choice, which is the procedure of choice in case of palpable nodes. This involves clearing the superficial as well as the deep inguinal nodal basins. And what should be the extent of the lesion? Superiorly, the extent is by a line joining the anterior superior iliac spine to the pubic tubercle. Laterally, a line 20 centimeter down perpendicular to the iliac spine. Medially, a line 15 centimeter down perpendicular to the pubic tubercle, and inferiorly, a line joining these 2 points. In the radical one, it will also involves ligating the saphenous vein, and only the femoral vessels are bad. Median lymph node count in such a radical inguinal lymph node dissection is to the tune of 10 to 11. Now coming to the modified inguinal lymphadenectomy, aim of this template is to remove the nodal stations with the highest probability of being involved, that are the central and the superior zones, while minimizing the morbidity. A 4 centimeter incision parallel to the inguinal ligament is made. This is a horizontal incision because horizontal incisions are reported to be more in line with the pattern of blood supply, and this causes less flat necrosis when you compare with a vertical or a lacy S incision. Modified inguinal lymph node dissection is bounded medially by the lateral border of the adductor longus, laterally by the femoral artery, superiorly by the external oblique just above the spermatic cord, inferiorly by the fascia lata just beyond the fascia of fossa ovalis. And in this case of modified inguinal lymph node dissection, we preserve the saphenous vein, and it does not include tissue lateral to the femoral artery or distal to the fossa ovalis. Now, superficial inguinal lymph node dissection is performed via a 6 to 8 centimeter horizontal incision, 1 centimeter inferior to the inguinal fold. Procedure involves excision of all the nodal basins, which are superficial to the fascia lata, from the adductor longus medially to the sartorius laterally. Long saphenous vein is preserved, and in this superficial inguinal lymph node dissection, the median lymph node count is around 8 to 10. Now coming to dynamic sentinel node biopsy, here an intradermal injection of radiolabeled sulfur colloid is given the day before surgery. and with lymphoscintigraphy. Ultrasound guided FNAC from palpably enlarged nodes that fail to pick up colloid activity. Intradermal injection of patent blue dye just before surgery is another modality. This identifies the hot nodes by a gamma probe utilized during the surgery. Intraoperative palpation of the inguinal region. Then you have to excise all the hot blue and palpable nodes which are sent for frozen section. Then exploration of groin when no activity on pre-operative lymph node scintigram is around 4 to 6%. Now, serial sectioning and immunohistochemical staining of the nodes instead of routine paraffin sections. Now, dynamic sentinel node biopsy, modified dissection templates are usually adopted to decrease the morbidity in those cases of lymph node dissection. No benefit from pelvic lymph node dissection. So one should not contemplate on a pelvic lymph node dissection when there is only single inguinal lymph node involvement. When you find that the cloquet node is unwilled, what you know, the cloquet node is a sentinel node, which is the superior most of the deep inguinal nodes and the inferior most of the external iliac nodes. So, and then second, another factor is that when there is no evidence of extranodal extension is found, and on biopsy, found that there is no grade 3 tumor in an involved inguinal node. So in such situation, there is no benefit in carrying out a pelvic node involvement. When you do a pelvic node involvement, when you find that when you do a radical inguinal lymphadenectomy, there are more than 2 or more inguinal lymph node are involved. The size of the node is more than 2 to 3 centimeters. There is evidence of extranodal invasion, and on frozen biopsy, you find that there is grade 3 lesion. Then ipsilateral pelvic node dissection is mandatory. My take home: penile cancer is a rare entity in developed countries, quite common in developing and undeveloped regions. Aggressive disease associated with human papilloma virus infection as the main risk factor. Early local and regional disease are surgically curable. Metastatic disease remains quite a challenge. Discovery of molecular alteration and knowledge of immune tumor microenvironment have emerged and offers potential targets for drug development, with the new insights providing in the domains of targeted therapy, immunotherapy, and molecular testing. The scope of penile cancer continues to evolve. Nowadays, even radiosensitizers are available, which if you give radiosensitizer drugs, it becomes very effective for radiotherapy. When you combine with radiotherapy and radiosensitive drugs, you can tackle even micrometastatic conditions. Thank you for your patience.
Thank you, sir. Thank you. Thank you very much. I think it was less time, but you have covered it so well. A whole subject is covered, I think. Right, pre-malignant conditions to evaluation to the treatment. Thank you very much, sir. Now we come to the last talk of the day. It is a very important condition. I think the evaluation of which is also controversial. Management is also different in different type of guidelines, and none other than the master on this subject, Dr. Venkatesh Krishnamurthy. Over to you, sir.
Thank you. Thank you, Dr. Arun. Is my screen visible?
Yeah, visible. Only full screen, sir. You can do full screen.
It's full screen.
No, sir. It is slide view only is coming.
Are you seeing it now?
No, sir. It is coming. Yeah, now we are seeing, sir. Absolutely right.
Okay. Yeah. Thank you. Thank you very much, Dr. Arun. I thank ISU and the USI for this opportunity to participate in this academic session. I don't know how many of you have an appetite for a lecture at the end of this day. I'll try and make this topic as interesting as possible. I can't think of any subject occupying so much of attention and study as the management of VUR in children. The more we know, the less we seem to have understood the subject in its entirety. I'm going to cover this topic. I am not going to cover it from the theory aspect. I'm leaving out all the clutter. So how you will investigate, how do you look at it, antenatal hydronephrosis, because 15 minutes does not permit me to cover all that. But I'm going to talk of the more important aspects, which is the management aspect of the psychoureteric reflux. There are many unresolved issues in its etiology, its diagnosis and management. The reason we find it's unresolved is because the more we seem to be treating it, we find that the ultimate goal of preventing renal damage has not yet been achieved. Why is VUR important? It is because of its relationship to UTI and therefore to renal scarring. And the more scars, then there is hypertension, CKD, and ultimately ESRD. And therefore, the interest in seeing that we give the best outcomes. A few basic points as the foundation stone for this subject. Reflux is not the cause of UTI. Reflux facilitates pyelonephritis. Anatomy and function are entirely different events in the outcomes of reflux. What are our goals? Management should prevent UTI, should prevent scarring, should prevent hypertension, CKD, and ESRD. This is going to be a recurring theme in my talk so that you understand what we are doing. So first, the first question, has this modern management, that is antibiotic prophylaxis, endoscopic intervention, surgical correction, all this, has it resulted in the reduction of incidence of ESRD? The answer is no. I hark back to the seminal paper of Craig et al. From Australia, multi-institutional study. They have done a study over 3 decades and followed up these patients, and the incidence of reflux nephropathy has not come down. In older subjects, it is the same. In up to 44 years, it is the same. So whatever it is we are doing, we seem to have lost the primary cause for this phenomenon. Has unreflux reduced the incidence of hypertension? No. Earlier, the debate was medical therapy versus surgical therapy, which is better? But now the debate has moved on to what is good in medical therapy and what is wrong. Similarly, for surgical therapy, it is not one against the other. In medical therapy, all the guidelines are very clear, categorical, that you identify and manage lower urinary tract dysfunction. Make sure that you identify it because it is present in up to 35% of children with VUR, and treat that aggressively. The incidence of UTI comes down drastically and VUR resolves far earlier. Next, the other part of medical therapy is continuous antimicrobial prophylaxis. Does it prevent recurrent UTI? World over, we refer now to the Revere study, which was published in 2014. It reduced infections by 50%. Those on CAP had a 13% incidence of UTI. Those on placebo had nearly double. It reduced the incidence of UTI, but not of scarring. Now that is very important. So instead of focusing on those who had UTI, we need to look at the 76% on placebo that did not develop UTI. Perhaps the answer to managing BUR better lies in this and not on those who had UTI. This is a revelation that we really understand very little about UTI, renal injury, and the relevance of reflux. So current concepts in antimicrobial prophylaxis. Again, I repeat, the goal is to prevent UTI and to prevent scarring. And somehow, so far, whatever we have been doing has not given this result. The first question, duration, for how long prophylaxis? There is no definite answer. Some people say 6 months, some people extend for 1 year, some people say till the age of 5. So obviously we do not have a real answer for this. Currently the consensus is till the child is toilet trained and lower urinary tract dysfunction has been treated. The next is its limitations. We still have breakthrough UTI in 25 to 38% of these children. They develop antimicrobial resistance. There is adverse reaction and a problem of compliance. Downsides, poor compliance. Efficacy of the various antibiotics. Unless we understand this thoroughly, especially in infancy, it is not going to be of no use. Compliance. In this result from the National Pharmacy Claims Database, 40% of patients were, only 40 were compliant. In this study, only 31% were non-compliant, but only 17% were at least 80% compliant. It decreases further by the first year. So probably this is the reason why it is not helping as much as we think it should. So we have this risk of UTI continuing with CAP, increased antimicrobial resistance, but the most important part is that there has been no difference in the scarring. The long-term effects of antibiotics on the microbiome are very well known now. We see that there is inappropriate immune activity, incidence of obesity in older children, and malignancies and so on. So let us look at what the guidelines are now telling us about this. Very categorical, EAU has said that there is a lack of robust prospective RCTs. Most of the level of evidence is grade level 3 or less. So most of it is panel consensus, like I mentioned about the duration of CAP. So what has happened after the reviewer study was published? A lot of reviews have happened on the data. The raw data has been analyzed and there are several publications. So right now, there seems to be a consensus that we will reserve antibiotic prophylaxis for a high-risk group, uncircumcised males, children with LUTD, and those with high-grade reflux. Let's look at this. So CAP is not needed in every patient with reflux. CAP has no benefit or minimal benefit in low-grade BUR. CAP is considered useful in grade 3 and 4 reflux, but not in preventing renal damage. So this somehow seems to be a specter that is haunting us in our management of reflux. CAP has better benefit in children with LUTD, but remember the focus is on correcting the LUTD and not depend on antimicrobial prophylaxis. Let us look at this statement. Treat all patients diagnosed within the first year of life with prophylaxis, regardless of the grade of reflux or presence of renal scars. Strength rating, weak. Offer definitive surgical correction to patients with frequent breakthrough infections, weak. So all the citadels that had seen us through in so many for the past 2 decades in our principles of VUR seem to be breaking down. Offer surgical repair to children above the age of 1 presenting with high-grade reflux. Again, the strength rating is weak. If the parents prefer definitive therapy, then they suggest that it's a strong recommendation. Again, select the most appropriate managed options based on all these things like bladder function, bilaterality, grade of reflux, and so on. The strength rating is weak. So the summary of evidence, there is no evidence that correction of persistent low-grade reflux without symptoms offers any significant benefit, which means you can let these grades of reflux remain. Children younger than, so what does the AUA say? Is it any different? No different. CAP for children younger than 1 year with a history of febrile UTI for reflux grades 3 to 5 and those with bladder bowel dysfunction, that is LUTD. CAP is recommended. It's a recommendation, it is not a standard. CAP remains an option in all other patients. Now, what about surgical correction? So we've dealt with 2 aspects of medical therapy. One is identifying LUTD and correcting it in children with reflux, and the other is about CAP. The next is the surgical management. What about surgical management? Surgical correction should be considered in patients with persistent high-grade reflux, but there is no consensus about the timing and the type of surgical correction or the benefit gained. AUA, again, surgical intervention, either open or endoscopic, is an option. Again, this is not standard. So this runs in the face of everything that we have been practiced, especially for urologists who cannot watch a reflux and not want to intervene. So true, the child has high-grade reflux, but the reflux has little to do with the infections. Just because there is an anatomic abnormality does not mean you go and correct it. This sort of sums up our present understanding. The other part of preventive surgery, which is not at the VUJ, but as circumcision, to be done as prophylaxis? No. But after for those children with UTI, yes, it is beneficial, reduces the incidence of UTI by 90%. Now there's a qualifier. If you think that the child is high-grade reflux, then maybe circumcision can be offered. As against this, we also deal with patients in the adolescence, that is transitional urology or adult VUR. Transitional urology, post-surgery at the VUJ, that is post-reimplant, late-stage outlet obstruction with reflux, neurogenic bladder, transplant allograft VUR. Now in these, our approach seems to be so very different. Nobody is in a rush to go and treat it, especially persistent reflux after reimplant. We do know that pyelonephritis, even in the adult, can cause scarring, and yet our approach seems to be very different. Allograft VUR, even for symptomatic grade 4 to 5, though they say it may lead to graft dysfunction, there is low level of evidence for surgical referral. Perhaps this gives us grist to the mill to see how we should be approaching these patients. How do we follow up? This is important. Annual blood pressure monitoring, height and weight recording through adolescence to look at milestones, urine analysis for proteinuria and bacteriuria, urine culture if infection is suspected. And therefore, never leave out the role of the nephrologist in your management of the VUR. Simple, VUR is not a single simple disorder that we considered it earlier. You see reflux, go and correct it. No, there is a lot more that is happening in this presentation that we yet have to understand completely. I quote Warren Snodgrass, very telling comment. We overtreat VUR to avoid undertreatment simply because we haven't understood it. So there is a lot of research going on in the genetics of VUR, molecular markers, diagnostic criteria, most important, who actually will benefit from this therapy, and so on. I hope this sort of sums up where we are with VUR at present. Things are getting simpler, and I think we must resist the itch to go and correct that reflux simply because it is there. Thank you.
Thank you so much, sir. Thank you so much, sir.
Yeah,
This has
Dr.
been an
Gyanendra, please.
excellent. Yes, sir.
Yeah, continue, please.
Yeah, please, sir. This has been an excellent talk to end what has been a very educative session. Chawla, sir.
Yeah, no,
may
my only thing is when I was just listening to Dr. Venkat Krishnamurthy, I think in few slides he has covered the subject so nicely. Means if you pick up every single line was important, and this was in quantitatively little looking less in number of slides, but qualitatively a very high content in these slides. Thank you, Dr. Venkateshwar. I think none other than you can cover this controversial subject in a very, very short and crisp manner, and that can be only you only. Thank you very much, sir. And I think we had students who kept on watching you, means like they were waiting for your talk, and again, on behalf of USI ISU, thank you. Now, with this, I think we are coming to the end of today's program. That is so the second day of the virtual mock exam meant for the exam going students, but other were on also watching. It's my pleasure to, on behalf of the whole board of ISU, to thank all the faculty who have been a part of this program. They prepared their presentation, they spent time, they stayed there for the whole day, both the days, indicating their passion and for the teaching, as well as just being there along with your preparation for your final exam. Thanks to all the faculty again, and I thank all the students also who volunteered to be the examinees in front of all the seasoned examiners. Probably some sort of scare will be there, some sort of hesitation will be there, some sort of fear will be there, whether to, because we are online, whether we should come in front of the camera or not. But I think more or less I was watching, everybody did very well, and I think you would have gained some point, you would have gained some knowledge, you would have gained some proficiency, you would have learned some tricks of the trade. I think probably something which is left, or which is you feel is to be worked upon, I think you have enough time to cover up. I can only say best of luck for your exams, and I hope you all do very well in the exam. With this, I hand over to my other board member, Dr. Genitourinary Sharma, if you have any comment to make.
Sir, I think you have summed it up thoroughly and precisely. It has been a very good session for the residents, and they have been guided by teachers as to what the expectation is. And I think I would like to conclude by again bringing the attention of the students to what Dr. Shrenik Shah had said, that you do not see the case. You have seen enough number of cases in your residency. You have worked up the patients, you have operated upon them, you have treated them. So just approach those patients that you are seeing in the exams as another case that you have been seeing day in and day out. I think all the best to all the students.
Yeah. I can see Dr. Rajiv TP, you have been, you have started the trend of doing all this thing virtually, and you have any comments to make before we wind up? And then I'll go to Dr. Venkat Krishnamurthy for his suggestions.
Thank you, Dr. Arun. It was a wonderful work. I have been listening to you since evening, and all the faculties have done wonderful work presenting various cases, and they have touched everything, in fact, what is asked for the DNB and the MCH examination. Yesterday also it was a wonderful thing. So 2 days of elaborate coaching. And I'm very happy that the USI Smart Learning, which I have started, is going on full swing. And the MCH and DNB trainees, I don't have any doubt that they are, it has been very much helpful for them for the preparation of the examinations. So thanks to the Indian School of Urology, chaired by Arun Chawla, because I worked with him last year during the pandemic, doing this extensive program throughout the year. And you have been doing a wonderful work, Arun. And thanks to the USI for this activity of theirs for the MCH and DNB trainees. And thanks to all the faculties who have done a wonderful work. And the students also, I think around 75 odd MCH and DNB trainees were there. And I request them not to miss any of these USI programs, because it will be very helpful to you, not only now and even in your future practice as well. Thanks to everyone.
Thank you. One more just request to the residents. We'll be putting your feedback link in the group, and probably you need to do one favor, spend some time, answer all the questions, so that will form our basis for doing the virtual mock exams in the next half of the calendar year or the next year. Because with the situation improving, we are doing physical exam we had in Ahmedabad. Now is the turn of East Zone in September, and the status of virtual exam, how to do, how to plan, will all rest upon your feedback. So spend some time, give your feedback. We'll put in the group the link. Thank you very much. Thank you, Dr. Gyanendra. Thank you, Dr. TP. Thank you all those who have been here. Thank you. Good night, and all the best again. Wishing you for the exams.